Good morning, everyone. The meeting will now come to order of the California Healthcare Affordability Advisory Committee. Please note that this meeting is being recorded, and we will start with a roll call, please. Sorry, Jane.
Good morning. Joan Allen.
Present.
And please use your microphone, as she did, and make sure that the light is green, so you can press the button for it to go green. Barry Arbuckle.
Present.
Eliza Arjoyan. Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty. Adam Daughtery. Parker Duncan Diaz.
I'm going to try this, Mike. Did that go? We didn't have one of those. I have this here.
Good,
Present.
thank you. Yes.
Now I'll put that down.
Hector Flores. Stacy Heratos.
Have we unmuted?
David Joyner.
Present.
Travis Lakey. Tam Ma. Carolyn Nava.
Present.
Mike O'Day.
Present.
Janice O'Malley. Thank you. Thank you, Mike. Janice O'Malley. Marielle Riazza.
Present.
Sumana Reddy.
Present.
Yolanda Richardson. Christina Rodriguez.
Present.
Karen Savage Sangwan.
Present.
Andrew C. Stephen Shortell. Sarah Sorokin.
Present.
Ken Stewart. Suzanne Usage. Renee Williams. Abby Yount.
Present.
And as a
Madam
reminder
Chair.
to our, go ahead.
This is Hector Flores. We were muted at the beginning.
Yes.
Thank you.
Stephanie Klein. Stephanie Klein is also present. I was muted at the.
Thank you, Stephanie. I apologize for that. So noting that Stephanie Klein, Hector Flores, and do we have any other virtual attendees?
Yes, Janice O'Malley.
Janice, thank you. And as a reminder to our committee members attending virtually, we do need cameras on. And if you're going to step away, you can certainly send us an email and let us know. Great. And I'll go ahead and go. Carmen Comsty.
Present.
Great.
May I please chime in with Eliza? Our Joanne is present as well. Thank you, Eliza. Yeah. So thank you for turning your cameras on for members who are appearing virtually. And as Jane noted, if you need to step away, that's fine. We'd ask that you keep your camera on, even if you step away. That is fine. Just as we can step away in the room. So with that, we have a record of who is in attendance. And before we get started with the agenda, I'd like to introduce our attending board member, Rick Kronick, who is with us virtually today. So as you know, we have a board member, a member of the Healthcare Affordability Board who attends each of our advisory committee meetings. So staff does a careful job of gathering your input and conveying that to the board. And we always have a board member present also, and they helpfully add to the staff's sum up of the feedback that you give us. Also joining us, we have Jane Harrington helping with facilitation, and Jean-Paul Buchanan, a member of our legal team. So we're going to start with a review of the agenda. If we could bring up the agenda slide. So we got a lot of meaty topics for you today. Vishal and I will do our executive updates. We're then going to have an opportunity for each of the new advisory committee members to introduce yourselves and tell us why you were interested in joining this group. So we'll do that at the end of Vishal's remarks. Sheila Tatayan is here with us to give an update on cost and market impact review program, including some changes to the regulations, and she'll go through letting folks know what notices we've gotten to date. We're really excited for the first time to be talking about our equity and quality measure set proposal, and so we're pleased that Margareta Brandt and Jana King will be going over that content, and we look forward to your feedback about that. We have also an update on the total healthcare expenditure submission guide and regulations. And then, as you know, we've been working very hard on the primary care definition. Next up is our behavioral health definition, and so we'll introduce some concepts there, and of course take public comment after each of these agenda items. We will be moving item 4, the consumer stories on affordability, to the February meeting. I don't know if that was still supposed to be there. I don't think so. All right, disregard that. Okay, so importantly, we're going to next have our HCI land acknowledgement statement. So we had Indigenous Peoples Day noted a couple of weeks ago, and so we thought it appropriate to include one of HCI's equity statements, and this was developed by HCI's racial equity team. The Department of Healthcare Access and Information Sacramento and Los Angeles offices sit on land stolen from the Miwok, Nisenan, Chumash, and Gabrielina Tongva peoples. We acknowledge the resilience and fortitude of these and other Native peoples who, despite efforts at genocide, survive as cultures and communities today. Cross-generational trauma, systemic racism, and historic discrimination have taken a toll on Native peoples, contributing to health disparities, a lack of access to healthcare services, and barriers for Native peoples to become part of the health workforce. So I'm not going to read the whole statement today, but we do think it's important to share the statement and, more importantly, to take action on it. So very proud of the work that HCI is doing in our workforce work to note where there are Native American professionals who are represented in keeping with their representation of the community, areas where we need to expand that. I'm really excited that the behavioral health coach role that we've talked about, we actually have an overrepresentation of folks from the Native American community that are becoming behavioral health coaches to provide support to our young folks who we know are facing behavioral health challenges. We're very committed with all of our data programs at HCI to make sure we're lifting up those stories, specifically so that we can address racial disparities. We know that governmental entities, together with private entities, have had a role in very explicitly disadvantaging Native American communities, and so it's up to us to take affirmative action to address that. So wanted to share that land acknowledgement today. Moving on, I want to acknowledge that Secretary Mark Galley has stepped down, and as you know, is no longer our Health and Human Services Agency Secretary. He was a very strong supporter of OCA and this work. He chaired our board. He made it a point to stay on to make sure that he got to the Monterey meeting. That was really important to him. And so we appreciate his service during the pandemic and with the founding of OCA, and we will miss him. And we are very excited that the new Secretary of the California Health and Human Services Agency and a new healthcare affordability member is Secretary Kim Johnson, who started in October. Secretary Johnson was previously the director of the Department of Social Services, where she led a team of over 5,500 employees, serving millions of Californians through critical safety net programs such as CalWORKS, CalFresh, IHSS, the In-Home Supportive Services program, our foster youth, Before being DSS director, she served in a number of other leadership roles at the department, over CalWorks, the child care and refugee programs, and has over 25 years of experience working in both community-based organizations and government, focused on advancing the health and well-being of individuals, families, and communities most in need of resources. So we've had an opportunity to do a few briefings for Secretary Johnson. She was at our September meeting and has jumped in and very committed to this work and making sure that we make healthcare more affordable to all Californians. All right, I have a couple of brief HCI program updates. On the workforce side, we're doing a lot around behavioral health. So folks may know under the Behavioral Health Services Act and Proposition 1, 3% of the funding from those sources will be used by HCI to expand and support the behavioral health workforces. We've engaged in supply and demand modeling and development of a behavioral health workforce strategy. So if that's of interest to you, we have a lot of information on our website about that strategic plan. On the HPD side, I know the OCA side is always interested to hear HPD, and of course we have Ken Stewart and Joan Allen and others, and Kieran, all of whom serve on our HPD advisory committee as well. So we had an HPD advisory committee meeting last Thursday, had really great presentations from staff about some of the upcoming data products that will be available, and heard from committee members about their areas for prioritization of our data products. And we're very excited that very soon in the next couple of months, we'll be taking the first requests for data requests. So we're trying to get as much publicly available data out there in the community, and are excited that you all will be able to ask for your custom data sets as well. And then lastly, and very importantly, I'd like to discuss the Affordability Board's meeting in Monterey. So folks may know OCA staff and leaders from Covered California and CalPERS presented data that we have available to us that very clearly show that hospitals in Monterey are high-cost outliers. The presentations highlighted data in response to several possible explanations for high costs. So we looked at a risk mix, we looked at quality data, we looked to see whether there was more charity care or bad debt, payer mix, and none of those factors directly explain the higher costs that consumers are facing in Monterey. We had Professor Christopher Whaley from Brown University, who presented data that he has been working with. He also outlined policy steps that other states have taken to address high hospital costs, including the use of ambulatory service centers, which is something that we've heard talked about, taking action against consolidation in the health market, and capping hospital prices. So key findings from the meeting include, again, that health prices in the Salinas-Monterey area are both high and growing fast. Overall healthcare prices, both inpatient and outpatient, are well above statewide and national averages. The area experienced a 19% price increase from 2017 and 2021. And I have to say, as someone who sat in this position with the data over my head, just to see the validation of folks who have been living this and the data bearing out their experience was quite powerful. The Covered California region that covers Monterey County, Region 9, has consistently experienced higher costs and premium growth compared to the rest of the state, even though its risk pool is generally healthier compared to the rest of the state. So we were joined by Jess Galtman from Covered California, who shared that data. HCI annual hospital financial data finds Monterey County hospitals have positive operating margins, indicating profitability. The compiled data showed that from 2018 to 2022, CHOMP, Community Hospital of the Monterey Peninsula, and Salinas Valley Memorial Hospital had operating margins that were between 4 to 6 times higher than the statewide average. So we really felt strongly that we owed it to the Monterey consumers who have come to us so many meetings and asked us to come to Monterey. We really felt that we owed it to them to come to them this time to present the data that we had and to hear from them about their experiences. So it was very moving to hear from teachers, from 3 different school superintendents, from farm workers, from hospitality workers, from union stewards and leaders, former elected officials. We had former State Senator Bill Monning there and other community residents. And we heard impassioned pleas asking for the state to do something to lower the costs of care in the Monterey region, and very much, of course, take that to heart. As part of OCA's charge in analyzing the healthcare market for cost trends, we can conduct studies on the health care market, such as the impact of consolidation, power, profit, margins, and other market failures on competition, prices, access, quality, and equity. So as noted by the citations listed on this slide, OCA also has the authority to include research and market investigation as part of this study authority. So pursuant to this authority, I have directed staff to commence an investigative study of hospital market competition in Monterey County. The focus of the study is to assess market competition, consolidation, presence of a market failure, and any anti-competitive effects on costs, access, and affordability for healthcare services in the region. And depending on what we find, we may make a referral to the Attorney General, who may take further action. OCA will complete the investigative study by working with economic experts and will publish a report of our findings. So basically, we have shared what we already have publicly available, and this will dig deeper into what's happening with the market. Due to the investigative nature of the study, OCA will provide status updates, but will not disclose specific information about the study until the report is published. At the Monterey meeting, we heard from a number of consumers who conveyed concerning practices in terms of collection, billing patients while they were still under the course of treatment, and the like. So I'm concerned about these practices who are at least insensitive and may well violate limits of billing and collection practices. So we're seeking additional details about these practices to see if that legal line was passed. And then I want to acknowledge that several people testified at the board meeting in Monterey urging the board to adopt a sector target on high-cost outlier hospitals. So, and we heard that again at the last OCA board meeting in September. We laid out the steps involved in adopting sector targets and some considerations, and again followed up with our board at the September meeting to get their input about the possibility of adopting a sector target before 2027 and the parameters that we felt should be explored. So I do want to temper expectations. Our team, has multiple work streams with all the different pieces that we're working on. We still need to socialize with the board and the public. The initial approach OCA has developed for measuring hospital spending, so we'll do that in an upcoming meeting. Obviously, we can't have a sector target on a sector until we have a way to measure their costs. The team has been working hard to develop that methodology, and we'll share that. And it was important to hear from the board, as we did at the September meeting, about their thoughts about adopting a sector target sooner than the statute may have called for. So those are my updates, and with that, I'll turn it over to Vishal Pagani. After Vishal, I believe we're going to do questions after both executive updates, if we may.
Thank you, Director Landsberg. So today I want to provide an update on total healthcare expenditures data collection efforts here at OCA. In August, OCA received aggregate Medicare fee-for-service expenditure and enrollment data from the Centers for Medicare and Medicaid Services. This was data we received for calendar years 2022 and 2023 for the purpose of OCA publishing its baseline report, which is due in June. The TME, then we also at the same time collected total medical expenditure data submissions for commercial and Medicare Advantage plans for the same 2 calendar years. This data was due September 1st. And we held one-on-one meetings with payers in advance of this data submission to answer any questions and provide TA. We received submissions from 17 submitters. And then since then, we've been carrying out data quality assessments, and we are beginning to schedule one-on-one meetings to review each submitter's enrollment and total medical expense data. In February of the next year, we expect to receive total medical expense files from the Department of Healthcare Services for managed care organization plans. And then moving forward, we wanted to highlight some details from an interesting article published on Health Affairs this past summer in August, which analyzed data from 5 states with spending target programs. It was found that in states with a spending target, spending growth moderated in 22 compared to 2021, but still exceeded their respective targets. For 2022, these states set their targets between 3% and 3.4%, as shown in blue. Rhode Island was the only state to meet its spending target of 3.2%. It had the lowest rate of spending growth at 1.6%. Oregon's 2022 spending grew 3.6%, only slightly exceeding its 3.4% target. Connecticut also slightly exceeded its 3.2% target, with spending growth at 3.4%. On the other hand, Delaware and Massachusetts slightly exceeded their targets with 2022 spending growth or significantly exceeded their targets with 2022 spending growth of 6.3% and 5.8% respectively. And then on the next slide, this shows statewide spending growth in 2021 and 2022, just so that you could see kind of the year-to-year performance. So even though most states did not meet their target, spending growth was much lower in 2022 compared to 2021. Delaware's 2021 spending growth was highest at 11.2%, followed by Massachusetts at 9%. This growth has since moderated, and spending increases in 2022 largely mirrored pre-pandemic levels, but still exceeding their targets. While Delaware and Massachusetts continued to have the highest spending increases, their 2022 spending growth was much lower than the 2021 levels. So the next slide, points to some of the potential drivers of the spending growth. Retail prescription drug spending was generally the fastest growing spending category across states. In 2022, hospital inpatient spending dropped in 4 states and remained flat in 1. The authors of the Health Affairs article suggest that the 2022 slowdown in spending is unlikely to be long-lasting due to the significant reimbursement increases that healthcare providers sought in their contract negotiations with insurers following the period of high inflation in late 2021 through 2022. So this will likely play out in the form of high spending growth in 2023 and 2024. Now that these states have collected and analyzed several years of data to understand the drivers of spending, the authors note that the focus must turn to implementing policies that address high and rising spending and make healthcare more affordable. And then not shown on this slide, I wanted to shift over to a different topic, which is progress in 2 of our health system performance work streams. In June, the board adopted or approved the alternative payment model, or APM standards and adoption goals that this committee had reviewed in May. The standards provide a set of 10 best practices to guide APM contracting between providers and payers, and the goals are intended to promote a shift from fee-for-service based payments to APMs in order to align financial incentives that support equitable, high quality, and cost-efficient care. And as a reminder, our APM goals are set are based on 2-year goals leading to a final goal by 2034 for the percent of members attributed to a consensus framework, the healthcare payment, learning, and action network categories 3 and 4. So our goals are differentiated by market. 95% of members attributed to APMs for commercial HMO and Medicare Advantage, 75% for Medi-Cal, and 60% for commercial PPO. And then at our most recent board meeting on October 14th, the board approved primary care investment benchmarks. The approved benchmarks include an annual improvement benchmark of 0.5 to 1% per year for each payer by line of business and product type, and a statewide investment benchmark of 15% of total medical expense across all payers, products, and lines of business by 2034. So primary care investment at this level will align California with the highest performing health systems internationally. We appreciate this advisory committee's input into both the APM and primary care investment work. Our next steps involve preparing to collect data to measure APM adoption and primary care spending, and you'll hear more about this later today. And then just briefly, we've indicated in a blue area the areas of the presentation where we seek advisory committee input or recommendations on areas in the statute and other areas requested by the board or OCA. And then lastly, I wanted to take a moment to introduce the new members of the committee. So the new members are shown in red text on the screen. So starting with Travis, we'd like to ask the new members to introduce themselves and take 1 minute to tell us about the role you hold within your organization and what draws you to this, to the work of the Healthcare Advisory Committee.
Hi, excuse me, sorry about that. My name is Travis Lakey. I'm the CFO at Mayor's Memorial Hospital District for about 15 years. I have an interest in the committee because rural health, we have low volumes and poor payer mixes, very high governmental, so definitely have some concerns about the committee and any decisions that are made and how it affects rural health care, so definitely want our voice to be heard.
Thank you, Travis. Next, we'll go to Christina Rodriguez.
Hello, my name is Christina Rodriguez. I'm a physician assistant. I work for Altura Centers for Health. It is a rural health center in Tulare County. And so I am here, and I was interested in joining this committee because I am here to advocate for our patients. And I'm very happy to be here.
Yeah, welcome. And then the next person we have is Marielle.
Hi, good morning. Marielle Reyataza, my pronouns are she, sha. I'm the executive director of the National Asian Pacific American Families. We just changed our name, Allied for Substance Awareness and Harm Reduction. I'm interested in doing this work because I represent not just community-based nonprofit organizations and really folks who are organizing on the ground, but also as someone who has been a healthcare worker. My background is medicine research, and I also taught, which very nice to see CJ Howard here because we've known each other from the past. So here because all of our, it's important to have the business standpoint, the policy standpoint, but we also work very closely with our organization. So I'm hoping to not only bring some input, but also share back with the community. Thanks for having me.
Thank you. Katie Bessler.
I'm Katie Bassler. I am a labor leader and educator in Salinas in the the infamous Monterey County. I've been coming to these meetings for over a year, and it's given me an opportunity to hear what the work that the OCA board is doing and the work that the advisory committee has been doing, and I wanted to be a part of it. We have a crisis in education, attracting young college graduates to our profession, and the cost of healthcare is just one more barrier. And I want to attract the most qualified educators to our profession. But if healthcare is unaffordable, they're going to go elsewhere. So that's why I'm here, and I'm excited to work with all of you.
Lastly, Stephen Shortell.
Yeah, thank you. I'm the one academic on this group. Somehow one was allowed, and so I'm happy to serve. There's 28 of us, so I'm clearly outnumbered here. But I'm Professor Emeritus now of Health Policy and Management at Berkeley. And I've spent my career, really, I study the healthcare system. A lot of my work, my background's in the behavioral sciences. I've had a lot of economics, but I'm not an economist, card carrying. But I study how payment models and organizations influence affordability and quality of care. And I have a particular interest in working with all stakeholders in how we continuously improve care in our country because it's very poor. Affordability is the main chart, no question about that. We need to make it more affordable, but there's also ways in which we can make it higher performing as well and eliminate some of the harms that patients and families receive. But there are pockets of excellence. A lot of it's around the table here. And the other thing I should say, I think, would be I'm a member of a National Health Policy Group. It's a Better Healthcare Policy Group, and we work with health plans. We have 3 working groups with health plans and with provider organizations and with measurement people and also with regulators and Families USA and others. And we're trying to figure out all the work that's being done here and in the other states on how we can make healthcare more affordable and higher quality at the same time. So I'm evidence-based. I'll say, well, what's the evidence for that? Or if I have evidence I can introduce, I'll certainly try to do so. Thank you.
So now I'll return to Jane Harrington to facilitate committee discussion on the executive updates.
Great. So discussion from the committee first, and then we'll move to public comment. I think David Joyner, you had a question?
I have a question about Monterey. So I saw your note about payer mix, which was perplexing to me. I don't think I've ever met a hospital where the percentage of Medicare and Medi-Cal isn't a significant influence over their commercial rates because of the under reimbursement. So when you say payer mix wasn't an issue, do you mean it is an issue, but it's not enough to explain the full cost? Or are you claiming that payer mix doesn't influence costs for commercial insurance?
Thanks very much, David. So we did present, the OCA staff presented data on the payer mix. And so CHOMP, for example, does not have more Medi-Cal patients than the statewide average. So we compared each hospital to the statewide average. So I believe Salinas and Natividad do have more Medi-Cal than the statewide average, but not the others. Chris Whaley also talked about pushed back on the notion that there's necessarily cost shifting, and there is not evidence that there's a correlation between a high government mix and profitability. So Medi-Cal financing is incredibly complicated. There are many, many supplemental payments that are going to these hospitals. And so I think we need to take a more nuanced look when we just say that Medi-Cal isn't sufficient.
Yeah, I think just saying that they have the same percentage as others is not really that compelling in my mind. And I think it's to say that payer mix has no impact on your cost structure flies in the face of common sense when you look at the reimbursements that have come from the government programs. So from my point of view, my experience tells me that analysis isn't sufficient.
Thank you. Stacy?
Good morning. Just a comment on the spending growth. And in 2022, I think 2023 will be a lot worse, as well as seeping into 2024 as well. Specialty pharmacy is not necessarily retail pharmacy. It depends on if the payer puts it in the prescription drug benefit or if it's in kind of Part B aspect in terms of Medicare, but also the commercial plan. So that growth target will knock your socks off. Just a comment.
Thank you, Parker.
Good morning. A question back from slide 10, which is when you're sharing about who submitted, and it says Medicare FFS submitted in August, and then you shared that 17 submitters from the Medicare Advantage or the commercial plans that submitted. Can you give us any idea of that? Is that 1.7% or is that 93% of them? And any information on why they're late?
You're referring to the 17 submitters on the slide?
Yeah, you shared that. I just didn't have a sense of the context. Is that a few? Is that most of them? And is there an outstanding submission date?
Yeah. It's we had 18 submitters. I believe there's one that's kind of going through some data validation in terms of the files passing our validation checks, but we had 18 total registered submitters.
Okay, thank you. Go ahead, Marielle.
Yeah, thank you for giving us the chance to come back to this topic. I have a couple questions about some of the findings in the OCA August board meeting in Monterey County. I was wondering if there was any data on like frequency of procedures, percentage of different specialties, and perhaps even severity of disease. Was that also collected and will also be considered in these reportings?
So the data we presented on in Monterey was from HCI annual financial data, which does include utilization metrics and expenditure data.
Mm-hmm.
It doesn't get to the level of, there are some ways you could look at kind of cost centers and so on. But to the level that you're speaking to, that's a little more granular and would require claims data. And our data was focused on publicly available data sets.
Okay, understood. I have a couple more questions.
I just would say the Covered California did, however, share some data around risk mix. So not to the extent of like specific procedure codes, though.
Okay, thank you. And then I was also wondering, thank you for sharing that report from Health Affairs. Very curious about, which state has met their metrics. So wondering if there's any consideration about demographics and if there's any trend in what we're seeing in the homogeneity or heterogeneity of the demographics in these various states, perhaps? Is that something that we're interested in looking at, or that we can?
So when you mention demographics, are you referring to like race, ethnicity?
Yeah.
Okay. So the spending data isn't collected that way. We do know kind of general stats. Massachusetts tends to have a more homogeneous, white population. But those are kind of more contextual. The spending data itself is just kind of spending on members for their covered benefits. We wouldn't be able to do like a race, ethnicity analysis based on that data.
Can we foresee that might be valuable data in the future, and maybe perhaps data that we might collect coming up, especially with SPD 15 and the task of collecting disaggregated data?
Yeah, I think that the issue would probably be that would be interesting and is important. I think the issue is that it wouldn't be the spending data itself. We have other data sources here at HCI, including the healthcare payments database, and we are working on to make sure that the race, ethnicity identification that's well populated, so that we are able to do those types of analyses in the future.
Okay, thank you. I appreciate that.
Thank you. I've got a few more committee members with questions or comments, so we'll go to Joan, Stephen, and then Ken, and then reminding our virtual attendees to please raise your hand if you have a comment or question. Joan?
Regarding the Monterey cost and market impact report, at the next advisory committee, would it be possible to get an update not on the contents of that report, but just the shape of it? What sort of things will you be looking at? How is that report coming together? Because it feels like, since this is the first CMIR, that you're taking on, it would be really interesting to see how that is progressing and could be a place where the advisory committee could potentially give feedback on the shape and parameters.
I guess I didn't have a working mic. Thank you for your question. So I want to clarify, this is not a cost and market impact review. This is an investigative study. So we will do a cost and market impact review on a proposed transaction, and this is not a proposed transaction. This is an investigative study that that our director has directed us to do. So it will be different than a cost and market impact review, and it is investigative in nature under our government code authority as a regulatory agency to conduct investigations. So that's why we won't really be speaking about the shape or preliminary findings until we publish the final report.
Okay. I would assume this won't be the only one of these investigatory reports that we do. And it would be interesting as it progresses to hear how you are thinking about that report. This really is a landmark investigation. And so understand completely not seeing preliminary findings, but just some kind of interim discussion of how you are thinking about just the concept of doing these sorts of reports would be helpful.
Thank you.
All right, we'll move to Stephen, then Ken, and then Carmen.
Yes, briefly back to the health affairs states. It would be useful using some other data sources to look at some of the quality metrics that those states are using as they also, have their spending targets. So over that period of time, I assume that some of the quality measures I'm familiar with in those states, that if anything, quality stayed the same or improved. But it would be useful to see whether or not we could look at that. I know they didn't in the health affairs article itself, but I think it's something that could be fairly easily done and then feeds into the discussion we're going to have later today about the quality and equity measures we're going to use here in California.
Yeah, thank you, Steve. So I know Delaware and Massachusetts in their reports do have sections that focus on quality. So that is something we could look into in the future. And our program will definitely not just report on spending, but we also want to report on quality as well.
Yeah, great.
Ken, and then Carmen.
Okay, I have to put my HCA and HPD hats on sideways here. I think the work you're doing is great, but I'm concerned a little bit whether the rapid direction that HCA is going.
And can you pull your mic?
That the rapid direction that the HCA is going to dramatically expand the resources needed from the HPD or the scope of the data that has been collected. Because when we started the HPD, the intent was to make it the most comprehensive database in the country, but we also knew that we had fiscal constraints, either working off of the state's original allocation, but then it has to be self-sufficient by next year, I believe. So, I'm just curious whether there's consideration being given to the requirements expected from the HPD.
Yeah, Ken, I'm not sure exactly which piece you're concerned about. Is it the investigative study or the sector? I mean, we can only get out of HPD what we can get out of HPD. And so Vishal's team is working very closely with Mike's team on the HPD side. You're exactly correct that the general fund appropriation for the HPD effectively runs out at the end of this year. And so we'll be looking to the legislature for ongoing sustainable funding. Appreciate, your measured, very supportive approach with the HPD, because we know there's a lot of excitement about the data and we can't be all things to all people instantaneously. So we think there are exciting data products coming out of the HPD and that we need to have realistic expectations. So the the OCA team is definitely working with the HPD team to see what's feasible in terms of supporting the OCA work.
Okay,
Thank you.
Thank you.
My question was comment was similar to Joan's about the Monterey report. So I guess my question was, I think you said that there was potentially going to be some referral to the AG's office in the study. I guess my concern is that I don't want the Monterey report to be limited to. I know that there was discussion at the last OCA board meeting about the AG's authority on and the relationship between OCA and the AG's authority and various attempts to clarify and or expand what the AG's purview is in terms of antitrust being able to intervene in anti-competitive behavior within healthcare markets. So I just want to make sure that, is the study and the whatever recommendations or referrals are made to the AG's office, if they're going to be strictly limited to, existing antitrust law or whatnot, or, in my interpretation, OCA has a little bit of a broader authority to do a more nuanced review without specifically looking at, say, the Cartwright Act or the AG's Healthcare Review Authority. So I guess the two questions that I have are, what exactly is the connection to the AG's office? What do you think you might be looking at in terms of recommendations or referrals to the AG's office? And, it goes back to what Joan was talking about is, what exactly, I guess, what exactly are the goals other than both just studying the report, and what are the recommendations that you think you're going to be looking at in terms of what OCA can do in terms of intervening in whatever market failures that you may or may not identify? Big question, sorry.
Question. That we are independent of the Attorney General's office. It was established for a very specific purpose, and our statute guides us. So everything we do is anchored in our statute. So we have a charge of public transparency. So in doing this investigative study, our mission is public transparency. So we study the consolidation in the marketplace, look at competition, look at anti-competitive effects, look at practices that might be anti-competitive. I guess I'm switching my content.
No, it's all correctly online.
Oh. And we also are charged with affordability. So we're looking at affordability, access, some of the same things that you see in our regulation for the factors for consideration in CMIR. We would be looking at effects on the labor market. And we can't really say, oh, what will we tell the AG? We don't know till we're in the throes of the investigation. So we will conduct the study, make our findings, publish a report, and it will be beyond what we think of a traditional antitrust law under California antitrust law or federal antitrust law, because we are looking at many more things, like I said, with our statute being our guide and our mission being public transparency. So if we do make a referral to the Attorney General's office, it will be of our report, it will be comprehensive, and then they will decide whether to take further action. And they would analyze it under unfair competition, state antitrust laws, and federal antitrust laws. So I think that does sort of help the shape of the question you were asking, Joan.
Thank you. Seeing no more hands raised and noting that we have no virtual hands raised from our committee members, that concludes discussion on this agenda item. We will now move to public comment. Please reserve comments on other items for general public comment period. This public comment period is on this agenda item. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room can line up at the podium. Those attending virtually can raise your hand. If you're dialing in, you can press *5 to raise your hand. It will track the order in which your hands were raised. During public comment, you will be unmuted when it is your turn. We also invite you to provide written comment at the email address noted in the public agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the advisory committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Looking to the individual at the podium, please go ahead.
Thank you. Members of the committee, staff, I'm Steve McDougall representing CFT, a union of educators and classified professionals. I also live in infamous Monterey County. I opened up my email last night on my ride up here and got an email from a PE teacher and a baseball coach at North Salinas High School. I'm going to read his email. It's open enrollment season, by the way. I feel completely stuck, powerless. Every year, they, not understanding who the they are, because healthcare is a hard thing to understand, raise our rates. The rates, almost completely negate what pay raises we get. This needs to stop. We need to put our foot down. I'll tell you what flies in the face of common sense. When you sit down with an entity like the Community Hospital of Monterey Peninsula, Montage Health, and they tell you they have a 4% margin, but yet August 28th, we find out it's 4 to 6 times the state average. And they're sitting on a $1 billion worth of B reserve. If I was representing hospitals on anybody, I'd be looking at Montage and telling them to knock it off. When consumers finally figure out this onion we have to unpeel, there's going to be problems for providers that behave like Montage Health. That's all I have to say.
Thank you. Looking virtually. Seeing no hands raised, going back to the podium.
Beth Capel for Health Access California. We were very impressed by the Monterey public meeting of the Office of the Healthcare Affordability Board, and would encourage all the members of this committee to review the presentation. It was compelling in laying out the high cost outliers and in establishing that cost shift does not occur in the way that is asserted sometimes. Indeed, the research presented by Chris Whaley indicated that the hospitals that do more Medicare and more Medi-Cal have lower commercial reimbursements, and those who have little Medi-Cal and little Medicare tend to have much higher commercial reimbursements, and that's certainly true of the Community Hospital of Monterey Peninsula as well. Again, it was not risk mix, it's not quality, it's not the payer mix that accounts for the high prices. It appears to be the reality that the Community Hospital of Monterey is functionally a monopoly, and Salinas Valley and Natividad are a duopoly, two hospitals and they have taken advantage. Health Access has asked that the board establish sector targets starting with the 3 hospitals in Monterey and moving on to high cost outliers, looking at the top 10 or 20% of hospitals, physician organizations, and health plans. We think it's important to move ahead to do this, to send the signal that the office and the board are serious about controlling healthcare costs and moving towards greater affordability for Californians. This committee has heard in the past a lot about lack of affordability. If you really want to hear the toll that it's taking on people's lives, listen to the public testimony from Monterey and think about the equity implications.
2 minutes.
We look forward to continuing to work on the hospital spending measures to assure that we're correctly measuring hospital spending. We've made significant progress on the inpatient side and have more to do on the hospital outpatient spending side. We think we can get there and get there in time to set additional cost growth targets that are much lower than 3.5% in time for the June 1 deadline next year. Thank you.
Thank you. Continuing on public comment, looking virtually, seeing no hands raised. Any individual in the podium, in the room, please step to the podium. Seeing no one at the podium and no hands raised, that concludes public comment on this item. We'll move to the next agenda item.
Great, thank you. So it's great to see you all again. It's been a while, and I'd like to welcome the new members. I'm Sheila Tatayan, and I am the Assistant Deputy Director for the Compliance Branch of the Office of Healthcare Affordability. And today I'm going to give you a program update. I want to review our revisions to our regulations that were adopted in August, and so we'll start with that, and then I'll provide you an update on the notices of material change that we've received thus far. So this slide is an overview of the changes that were made to our regulation, and I'll be going over each one of these with you. I won't read the slide out loud. Just give you a minute to take a look at it. I will call out one in particular because I don't have a particular slide on that one, and that is the request for confidentiality. So our original regulation allows a submitter to request confidentiality for their documents, and also to request confidentiality if they are requesting an expedited review, because sometimes they may be requesting expedited review of a transaction and be telling us confidential information to support the request for an expedited review. We added the ability for the submitter to withdraw if their request for confidentiality is denied in whole or in part. So you can see the practicality of that. A submitter comes to us with information, they're asking for confidentiality. Maybe it's about their financial distress, or maybe there's another reason they would like an expedited review, or maybe they just want confidentiality for some of the documents they're submitting in support of their transaction. If we deny the request, whether part of it or all of it, we wanted to make sure we gave them the ability to protect that information so they can withdraw it. We have an electronic filing portal, and they can literally let us know through the portal, and then we do not keep that information. All right, so I'll go over each of these changes as we advance the slides. So this was a change because we had some confusion. We take questions through our CMIR inbox, and we take some phone calls, but usually everybody contacts us through email. So some entities were confused about the use of affiliate and affiliation. So part of the test a healthcare entity goes through in determining whether they have to file a notice of material change with us is based on revenue. And we include revenue of affiliates in that calculation. We also talk about an affiliation because a proposed transaction can result in an affiliation. It's a partnership, a merger, a joint venture, an affiliation. So in the original regulation, the definition of affiliation contained the word affiliate. So people said, is that related in any way to the definition of revenue when I have to calculate revenue and I have to include affiliates? So we clarified this by removing that parenthetical statement of affiliate to avoid that confusion. Okay. All right, and we, practicality again, we removed the date of April 1st, 2024, because when we started out, it was for transactions that close on or after April 1st. Well, that date is passed, so it's no longer relevant. So that language was eliminated. And next slide. This is the change that every law firm's blogging about and writing about, because our original regulation focused on healthcare entities that were parties to a transaction. So if you were a healthcare entity and you were a party to a proposed transaction, you had to file notice with our office. Well, what we found was many times the entity that the transaction is about, in other words, the entity whose assets or control is being transferred, wasn't always a party to the transaction. They were the subject of. So it could be a specially created single purpose entity that was doing the deal. It could be a parent or grandparent entity that was doing the deal, but not the actual healthcare entities whose assets or control was being transferred. So we added the language. So it's no longer just a healthcare entity who is a party to the transaction. If you are a healthcare entity that is either a party to the transaction or the subject of the proposed transaction, you have to file with OCA. And to clarify that requirement, let's stay on that slide. That's okay. To clarify that, we defined what being a subject of. So you can see being a subject of the transaction means it concerns the healthcare entity's assets, control, responsibility, governance, or operations in whole or in part. And that in whole or in part is very important. So when I'm answering questions, when we're drafting responses, a good way to explain it to people is if the transaction is about you, you're a healthcare entity, then you have to file with us. We also added in 97435 to one of the revenue thresholds. So the second part of B is when it's a smaller entity doing a transaction with a larger entity. So if you look at the language, it's an entity that has 10 million and they're doing a transaction with an entity that has 25 million or more in annual revenue. So we added that it's not just doing a transaction with an entity that has 25 million or more in revenue. It can be the parent. It can be somebody who owns or controls 25 million, an asset, healthcare entity with 25 million or more. So I think the big question in people's minds is, does that mean private equity? Yes, it could mean private equity. So if you're a healthcare entity and you have 10 million in revenue and you're doing a transaction with an entity that owns or controls a healthcare entity with 25 million or more, then it would fall under our jurisdiction for submitting a material change notice. Okay. And then we clarified the geographic threshold. So we have revenue thresholds and we have a geographic threshold. So the geographic threshold pertains to healthcare professional shortage areas, HPSAs. So there was some confusion about this, and we're really focused on healthcare entities that are providers in a HPSA. So that's why we changed the language. So we clarified a provider or fully integrated delivery system that is a party to or subject of a transaction and provides services in a HPSA, because there was some confusion about that among payers. And if if I have an office in a HPSA, am I supposed to file? We're really focused on the impact to shortage areas. So we clarified and narrowed the language to providers. Okay, now we can go to the next slide. We get a lot of questions about revenue, and I'll just tell you, we tell people to use their general accounting method that they normally use in their ordinary course of business. In this instance, we did clarify revenue. So we could clarify that this was for the purposes of these regulations only. So when you're calculating revenue, you look to the regulations, because we have revenue thresholds for, do you have to file, all right? So based on the size of your entity, and we have revenue in the context of the transaction. So first you look to see if you meet the definition of healthcare entity based on revenue or geographic, and then you look at the circumstances of the transaction. And revenue comes up a lot in the circumstances of the transaction because it's what's going to happen as a result of the transaction. These are the circumstances that make it a material transaction. So for all of those we call them the C circumstances. For all the C circumstances, we clarified what revenue meant, and it is annual California-derived revenue. So, for example, if entities are joining together in the form of merger, asset acquisition, contract negotiation, is it projected to have annual California-derived revenue of a certain amount? I see nodding heads, so I think we can move to the next slide. So we added a little bit of teeth to our attestation. So originally, submitters had to certify under penalty of perjury when they submitted a notice to us. We collect a lot of information in these notices. It's very detailed, and you can look at our regulations and see just how much information we collect. And so we wanted to be sure that people didn't just say, well, this was all I had, or I don't know, because we ask for information about the other parties in the transaction. So we included a requirement that the healthcare entity submitting notice to us has to attest that they've exercised reasonable diligence in gathering the information that's required. So it's a reasonable standard. All right, next slide. And this slide, I won't read it out loud to you, but it just shows some of the information that we collect, and that the requirement is that the submitter exercise reasonable diligence in obtaining this information and providing it to our office. We also added cost targets to consideration in our review. We didn't have it originally because the cost target had not been adopted by the board. So once the board set the cost target, we could then put it into our regulation. But prior to that time, since it wasn't in existence, it wasn't in the first round. Okay, next slide. So these are the transactions that we've received notices for and reviewed to date. I'd like to go to the next slide because I think I'll go to the oldest to the newest. So starting with the Rehabilitation Center of Santa Monica, that was a skilled nursing facility and their lease was expiring. So a new operator was going to take over the skilled nursing facility, but it wasn't a situation where they were necessarily selling to the new operator. The current operator, Rehabilitation Center of Santa Monica, their lease was expiring and they were cooperating in staying in charge until the new operator obtained its license from the California Department of Public Health and made a smooth transition for the patients there. There wasn't any sale where they received consideration. 1338 20th Street is the name of the new operator. And they really just took over the existing equipment, the perishable goods, some equipment, and some miscellaneous things. They entered into their own patient contracts, everything else. It was sort of like a lease expired, new operator took over, took minimal assets of the former operator. That transaction was waived. And then the next two I'll discuss are with LabCorp. I'm sure you've probably been reading in the news about both Quest and LabCorp doing a lot of acquisitions in the laboratory space. So the first one that we reviewed was the sale of Invitae to LabCorp. Invitae is a genetic testing lab, and they were having financial difficulty. In fact, they were in bankruptcy. So LabCorp was the successful bidder in that bankruptcy auction, and it still had to go through us for review, and we did review it. Very small market presence in California, and we waived that transaction. The next LabCorp transaction was BioReference, and basically LabCorp was acquiring all of BioReference's testing businesses in all states except for in New York and New Jersey. And this laboratory testing was focused on clinical diagnostics and reproductive and women's health. Not a huge presence in California either. So you see what happens is some of these transactions are very large in size in terms of dollar amount, but the actual impact in California isn't reflected in that dollar amount because they're national transactions. That CMIR was waived as well. Okay, we can go to this slide. So with Cigna is exiting the Medicare Advantage market, and Healthcare Service Corporation is acquiring all of Cigna's Medicare business throughout the country. Cigna did not have any Medicare Advantage business in California. They have prescription drug plans across the country in all 50 states, but not many lives in California, only about 170,000 lives. Their Medicare Sup is also throughout the country, which Healthcare Service Corporation will also acquire. Not many lives in California. And then they also have supplemental health and life insurance. So the Department of Managed Healthcare licenses Medicare Advantage plans in California, but again, Cigna does not have any MA business that it sold to HCSC. We did notify the California Department of Insurance for the supplemental health and life products that they had. And that transaction was waived. A very large transaction you may have been hearing about, because there's been a lot of news about it, is this joint venture between Elevance and Clayton, DeBollier and Rice, CD&R, a very long-standing private equity firm. So Elevance, CD&R, and two other entities, Millennium Physicians Group and Apri Health, are combining in a joint venture to form Mosaic Health. And so actually you can find Mosaic Health on the internet. Not much information about it now because I don't believe they have completed the deal. So this is a primary care platform that will serve nearly 1 million patients across the country, and it's going to be in multiple states. In fact, Oregon also received notice of this joint venture. They're calling it a payer agnostic platform, and they're because of its focus on not necessarily on a particular type of payer. That's commercial, Medicaid, California Medi-Cal, and Medicare. So initially, CD&R will be a majority owner. Over time, that will transition to Elevance to become the majority owner. And so in California, the part that was in California was the sale of CareMore. They were known as CareMore. They're now Carelon. So the CareMore Medicare Advantage plans were put into this joint venture by Elevance. So this is an interesting one because it didn't come to us under our statute. Because CareMore as a health plan was regulated by the Department of Managed Healthcare, they had to file with the Department of Managed Healthcare. But because the transaction was much larger than just the transfer of a health plan or the sale of a health plan, the Department of Managed Healthcare ordered Carelon to file notice with us as well. So we would be able to look at the entire transaction. CareMore has just 31,000 enrollees in California. So right now, it did not have a big impact in California, but as you can probably tell from all that I'm explaining to you about this transaction, it's a very large national transaction and will be one to watch because it's in multiple states and we're talking about almost 1 million members. So they will need to probably acquire more providers, and they'll be advancing this use of a technology platform for care. Because one of the entities in the transaction is Apri, and they own Castlight, which is a digital technology tool for finding care. So that transaction we just waived last week. And then finally, Western Sierra Medical Clinic and Sierra Family Medical Clinic, they are two FQHCs, and they are in Nevada, Yuba, Placer, and Sierra counties. That's where Western Sierra Medical Clinic is. It's the larger of the two. And then Sierra Family Medical Clinic is the smaller, and it was operating in Nevada and Yuba counties only. The Sierra Family Medical Clinic was having a lot of financial distress and was in risk of going out of business. So Western Sierra took over Sierra Family to serve all of the patients. And so it was an interesting transaction for us because the attorneys that came to us to file this notice were actually doing it pro bono because of the dire financial stress that Sierra Family Medical Services was in. So they will acquire Western Sierra, will acquire Sierra Family, and then they will put 2 board members who were on the Sierra Family board onto the Western Sierra board. And those are the transactions that we've reviewed so far.
Well, looking for discussion and questions from the committee. We see Tam Ma, and then I'll go to David Joyner.
Thanks so much for walking us through these, Sheila. And so I want to make sure I understand correctly that you have received all of these, it's like 6 notices since April, and that all of the CMIRs have been waived. Is that correct? So the office has not actually begun conducting any CMIRs on any transactions.
That's correct. And so just to remind you of our process, in case you're curious, so we receive a notice of material change, and then our first step is to review it and see if it's complete. We have not received a complete one yet. We typically have to go back and ask for a little bit more information. Actually, they've been very clean. It's just that it's a lot of information. So we go back and forth with an exchange of, we need this, we didn't provide this. People are very cooperative in giving us the information, and then we start the clock. Once we say the transaction notice is complete, we start the clock, and they can see that on our e-portal. And then we take 45 days. If we're going to waive it, we need to let them know within 45 days. We've actually been ahead of that time schedule. And then if we are going to do a cost and market impact review, we will take 60 days to notify the parties because that is an appealable decision, and we want to make sure that everybody understands why OCA ordered a CMIR.
Thank you for your presentation. Just a question. Do you publish the rationale behind the waiver when you decide to waive? Is that published? What you kind of touched on the rationale with some of them, but you didn't cover them all today?
No, we do not. We do not publish the waiver. So what you will see on our website, and these are all on our website, you will see the notice, and the notice that's posted is exactly the information that the parties provided. And then you'll see whether we waive it or not. And you'll also see the start date for the time period. When we order a CMIR, we will publish all of this publicly available information for the transaction. We don't do that with one we've waived because it's waived. But if we order a transaction to CMIR, all the supporting documents that are not determined to be confidential by us will be on the website.
Thank you.
Joan Allen and then Barry Arbuckle. You have your mic.
I was really interested in the Mosaic transaction and that that came to you through DMHC, and with DMHC flagging that they needed to file. And that combined with some of the board discussion at the last meeting about who are we missing and how are we finding those cases where someone should have filed, and wanted to bring that discussion a little bit here. I don't know if is that for in your later slides at all?
No.
Okay. Because just in press releases and public information that comes through, I've seen at least one transaction that I looked at and said, why didn't they file? And so was wondering, what is the appropriate, how is the team thinking about that? And then what is the appropriate way to bring those to your attention even if they've already closed?
So we try very hard to monitor what's going on in the space of acquisitions and mergers. And we do receive some emails in our CMIR inbox when people want to alert us to a transaction either before or after it's happened. So we do get some emails regarding transactions even after they have occurred. When we think that there are transactions that should be filed with us or should have been filed with us, we have taken steps to reach out to the parties, asking for them to provide information and letting them know that we believe they should have filed with us and giving them an opportunity to tell us why they did not or why they believe they should not have filed.
Great. What's the public feedback loop on that?
What do you mean?
So how would I know that a transaction should have sought a CMIR, sought a material change notification filing, but didn't?
As just a general member of the public?
Yeah.
We don't have any way to sort of do a newsletter about transactions that are happening and whether they should have been filed with us. The emails that come to us are people who are interested, people in that community, people who are concerned about, the change in provider, hospital care situations. So I'm not really sure I could say that we have a way to let every citizen know of a transaction that should have been filed with us, if that's kind of where you're going.
Yeah, I would encourage you to look at that, because one of the things that we're trying to do with this process, because there isn't the ability to impose conditions like the AG has. There isn't the ability to block a transaction. This is a transparency process. And so if a private equity-backed medical group based in California acquires another medical practice, and I'm looking at it and saying, from everything I can see, this meets the definition. It was worthy of a press release by the entities. I don't know why that didn't go through a filing, and it would be helpful as we are looking at the consolidation in the space for there to also be that record, whether it's just on the website of these were transactions where we looked at it and said, this doesn't need to file. Or we looked at it and this should have filed. It would be really interesting to have that available, because as we're looking at whether it's roll-ups over the course of time or whether it is understanding compliance, yeah, because I've seen transactions I'm looking at like, why didn't they?
We'll take that back, Joan. We hear you.
Yeah, thank you for your input. And if there is a transaction that we encourage everybody, members of the public, members of our advisory committee, if there's a transaction that you think should have been filed with OCA, or you're wondering why didn't they file with OCA, our email, we have our email inbox and we respond. That's on the next slide. We respond to those emails.
That's actually very helpful. Thank you. That the right thing to do is, even as someone who's not a party to the transaction, to just use the email. That's the right way to
contact us. Yes. Yeah, it's the right way to contact. Like I said, we have received like inquiries about transactions in the nature that you're talking about. So far we've received 91 questions through the email, and we generally try to provide responses within 48 hours, and we provide written responses, but we are very clear that we do not provide legal advice. And so we do not have in regulation a pre-filing conference, but we do often meet with law firms. It's really mainly of law firms. So we've had 19 meetings with law firms basically about their clients, and they usually start out as hypothetical questions, and we say, well, we're not giving legal advice. We ask a few more questions in our response, and then we offer to meet. So those have resulted in very productive meetings, and we've helped law firms walk through our process to submit notices of material change on behalf of their clients.
So taking hands in order, we've got Barry and then Marielle and then Carolyn.
Sheila, thank you for reviewing these with us today. A question on the first matter that you raised that didn't have an accompanying slide, the request for confidentiality. I wasn't sure if I heard you correctly. You said if a request for confidentiality is denied, let's say in part, that the party can redact that or take that information back, or withdraw the entire CMIR request?
Either.
So you can take just that information back?
Yes.
It'll go forward? Yes. And then secondly, you may or may not be able to answer this, as a general rule, will you always publish the names of the party online while the CMIR process is ongoing?
Yes, because that information is contained in the notice, so the notices get published online, and they have to identify all the parties to the transaction.
I raise that because of the danger of that. By example, if as a nonprofit entity, if I wanted to acquire, say, 3 urgent care centers in Long Beach, California, where I have one of the largest ERs in California, to decompress the ER and move the work to a lower cost site of care, if the names were published, an outside company, let's say a publicly traded company that's very acquisitive, can come in and pay 2 or 3 times, because I'm required to pay fair market value. That's federal law. They can pay 3 times fair market value. So we're just basically inviting that to happen when we disclose the parties of these transactions.
Yes, and so to your specific question, so if somebody came to us with the notice of material change and said, we don't want to include the names of the parties, they'd need to request confidentiality for that. And then we would run that through our analysis. They'd need to show why. They'd need to show the justification, which is also laid out in regulation. And then we'd make that determination. And in your example, if we denied it, then they could withdraw the entire transaction or withdraw some portion of what they wanted to keep confidential.
Thank you.
Thank you, Sheila, for presenting all of this information. I have just a couple of questions. So coming back to CMIRs and when they are in process, is there any way that people can subscribe to some kind of listserv that when there's a new submission and that it's in process, that it triggers some kind of email blast?
They're on our website. As soon as we deem the notice complete, the transaction is listed on our website. I believe if you're on the listserv, I'm not sure if we're sending out notices with each new transaction, but that's really great input. I know Oregon does. If you're on their listserv class in Oregon, you will receive, but we appreciate that input.
Thank you. Yeah, that would be very helpful because, it's hard to just keep tabs of what's happening there. And then I also had another question about submission, like, third party, meaning not affiliated with either of the entities being discussed. Is there like a template or any guidance that's provided that will allow people to know what kind of information to submit and in which formats, perhaps even like references?
We don't have anything like that exists now. I think what you're asking is if somebody knows about a transaction and they want to notify us, is there some sort of template or sort of an outline of information that they should provide? No, we don't have anything like that. So appreciate that input.
Is that something that could be beneficial? I'm just asking, so I don't know if, yeah.
It might make some people more comfortable if they had sort of parameters. What we have found with the few that we have, it's more just really the person having a genuine interest or a concern and being able to send that to us.
That's helpful. I guess the reason why I'm asking about certain parameters and guidance is because, I think in part submitting these, requests also it involves some kind of understanding how all of these systems work. And so in some way, you don't have to mandate it, but having to collect certain information, right, draws also some more context about what's happening. So that's informative, not just for you all here, but also for those who are submitting it and those who are working with others to submit it. So I'm just gently asking if there's a way that more guidance can be provided, such as like example information and things like that, so that people who are submitting have some more context of how some of this works.
Thank you.
Thank
And
you.
we have, when we've received emails like that, we do reach out by responding to the email, and we do invite them to meet with us as well, because some people may not feel comfortable. It's always a balance, meeting people where they're at, when they want to notify a public agency, they may feel much better with those kinds of parameters or a format or a template, and others may just want that phone call back to them or that email back to them.
Carolyn?
Thank you. Thank you, Sheila. This is really very informative. I do have one question that pretty much swings back to what Joan was mentioning with Mosaic Health. This is one that I have just been personally watching through the news. It's really all over the place, so I'd be surprised if people aren't aware of it. My big concern is their description when they submitted reports is so vague, so convoluted, but when you look in the news media, what I read as a consumer is that we now have a company coming into California. Every single medical professional that joins them is described as becoming a business unit. That's the term they're using, is that these operating companies will become business units of the unified Mosaic healthcare system. They're not hiding this. They're being very, very upfront, very vocal in the public media, and using language that pretty much anybody can understand. And when you look at someone who is also in the same articles talking about revenues being 20, 30% higher than they were the previous quarter, and looking at billions of dollars, $2-3 billion in profit in the last year, I guess my question is just like Joan's, are we not doing more because we don't have enough information applicable to California yet? Or is the CMR waived because we're looking for more information from these applicants? I'm really wanting to understand the process, because to me this seems so blatant about what's happening. How do we not do more before it actually comes down on the consumers and there's no choices left out there?
So we look at the transaction that's been noticed to us, and in this case, as I mentioned, the Department of Managed Healthcare directed Caramore, now Carillon, to file with us because we would be looking at the larger transaction. We looked specifically at every party to the transaction and what was happening in California, because that's our jurisdiction, and we look at the impact on the provision of healthcare services in California. It does not mean that just because we waive the transaction, we stop following the transaction, because as I went through our regulations, you'll notice that CD&R is a private equity firm that now owns a healthcare entity. So when they enter into their next transaction, they're subject to our regulation. So it's, and we also have circumstances that include roll-ups and similar transactions. So sometimes I say this is the toe in the water. This is the first dip. It does not mean that we will not continue to look at the activity of this transaction.
I'm hearing you. It's kind of a trust the process. That's what I'm like sitting back thinking, trust the process. And I'm glad to hear that it's a continued look, because it's so easy. It feels so easy for someone to just slip in there under the water. And I know that's why we're all here, is to give credence and prudence to those types of activities. So thank you very much.
Thank you. Seeing no more discussion in the room, looking virtually, making sure we don't have any hands raised from our virtual committee member attendees. That concludes discussion on this item. We will move to public comment on this agenda item. If you'd like to make a comment and you're in the room, please step to the podium. If you're online, please raise your hand. Please limit your comments to 2 minutes going to the podium.
Beth Capel for Health Access California. Thank you for that overview. A few things to note from our perspective. We are surprised that there are so few transactions that have been considered compared to the predictions that there would be floods and thousands of transactions. So we too worry that there are people who should be approaching the agency who are not, and we appreciate hearing both that the public or members of the local community can raise concerns, and also that you are trying to look, the HCI is trying to look for transactions that should have filed. We appreciate very much the emphasis on making sure that the decisions, the information is public. The law is designed that way and to limit confidentiality. We think it would be helpful for all involved if there was some sort of brief summary of why a CMIR in a particular circumstance was waived. I'm thinking of the equivalent here of a case summary or something, not detailed blow by blow, dollar by dollar, but some sort of summary explanation, especially as we develop case law over time, to help all parties understand, those who are participating in transactions and those of us who are tracking this important responsibility. Otherwise, I fear that in the future, people will be skeptical that the authority has been used as intended. So I just think some modicum of explanation would be helpful. Thank you.
Thank you. Continuing public comment, looking online, seeing no hands raised. Back to the room, seeing no one at the podium. This concludes public comment on this item. I will turn it over to Margaretta Brandt.
Good morning. Margaretta Brandt, Assistant Deputy Director for Health System Performance. And we can go to the next slide. So in this portion of the presentation, we will be providing an introduction to our quality and equity measure set proposal. And joining me this morning is Jana King, our Health Equity and Quality Performance Group Manager. So this is an introduction of our proposal, and so we look forward to discussion and receiving all of your feedback today. And on the next slide, I'll start with a brief overview of the statutory language that guides our proposal, or guides our quality and equity measure set proposal. So the statute indicates that the office adopts the quality and equity measure set, and that performance on the measure set must be included in our annual reports. And it requires OCA to adopt and track performance on a single set of standard measures for assessing healthcare quality and equity across payers, fully integrated delivery systems, hospitals, and physician organizations. And these are non-enforceable measures that will be used to monitor quality and equity trends and promote quality and health equity as the spending targets are implemented. The statute requires OCA to use recognized clinical quality, patient experience, patient safety, and utilization measures, and to consider available means of reliable measurement of health disparities, including stratification or disaggregation of performance on measures by race, ethnicity, sex, age, language, sexual orientation, gender identity, and disability status. It directs OCA to reduce administrative burden by selecting quality and equity measures that simplify reporting and align performance measurement across payers, programs, state agencies, including leveraging existing voluntary and required reporting to the greatest extent possible. Statute also directs OCA to coordinate with the Department of Managed Healthcare, the Department of Healthcare Services, Medi-Cal, Cover California, and CalPERS, and consult with external organizations, consumer advocates, and stakeholders as we develop this measure set. And on the next slide, statute also specifies that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met. And performance on the quality and equity measure set may be used to inform a performance improvement plan, considering that statute indicates that the director shall not approve a performance improvement plan that proposes to meet cost targets in ways that are likely to erode quality and equity. And on our next slide, before we outline our proposal and the steps we took to develop it, we want to share with you our proposed purpose of this quality and equity measure set, which is to promote high quality, more equitable care for all Californians, to monitor changes in quality and equity as healthcare entities work to meet the spending growth targets, and to track progress towards OCA's overall goals to improve access, affordability, and equity for all Californians. And this slide provides an overview of the process and tentative timeline for developing and adopting a quality and equity measure set. So we began by reviewing quality and equity measures used by large purchasers and organizations in California and nationwide, as well as reviewing measures stratified or grouped by demographic factors like race and ethnicity and other measures of stratification. We then used what we learned to develop a proposal for measures to adopt and track, as well as health disparities methodologies. We then gathered feedback from sibling state departments, like those departments we mentioned previously that we are tasked with coordinating with, like DMHC, Cover California, and CalPERS, and other internal and external partners, and revised our proposal based on this feedback. And today we look forward to getting your feedback on the draft proposal. And based on today's feedback and public comment received, we will further refine the proposal before introducing it to the board in November. And we'll continue to have these discussions over the next several months, both with sibling departments and other stakeholders to refine the proposal before bringing an update to you all for additional feedback in early 2025. And we'll also solicit formal written public comment in early 2025. So, and this all leads up to an aim to adopt the quality and equity measure set by April of 2025. We may adjust this timeline as needed as we progress, and we will provide advance notice if we are adjusting this proposed timeline. And this all leads up to by June 1st of 2027, where OCA will publish its first annual report with quality and equity performance results using publicly available data. So now I'll turn it over to Jana King, OCA's Health Equity and Quality Performance Group Manager, to walk through the rest of the presentation, starting with our completed analyses to inform the proposed OCA measure set.
Thank you, Margaretta. My name is Jana King. I'm the Health Equity and Quality Performance Group Manager at OCA, and I use she, her pronouns. So here on this slide, we've summarized some of the analyses we completed to develop the proposed measure set that we're going to present to you today. So we analyzed over 300 quality measures used by healthcare organizations in California and nationally, including measures used by other California state departments, Cal Hospital Compare, the California Quality Collaborative, and national measure sets developed by CMS and the National Committee for Quality Assurance, or NCQA. We identified which measures are consistently used across organizations and reviewed how other organizations in California and nationally are measuring, analyzing, and reporting health equity and disparities. In addition, we met with internal and external partners to gather feedback and align efforts, including sibling state departments, including CalPERS, Covered California, DHCS, the DMHC, and the Integrated Healthcare Association, and internal partners within HCI. And go to the next slide, please. Okay, so this slide is a high-level overview of our proposal for the quality and equity measure set. We are proposing to adopt all or a subset of 3 publicly available measure sets to measure quality and equity across healthcare entities, including payers, physician organizations, hospitals, and fully integrated delivery systems. So for payers, we propose adopting the full Department of Managed Healthcare's health equity and quality measure set measures and stratification or grouping requirements. For physician organizations, we propose adopting a subset of the Center for Data Insights and Innovation's Office of the Patient Advocate, or OPA's, healthcare quality report card measures. And for hospitals, we propose adopting the full HCI Hospital Equity Measures Reporting Program measures and stratification requirements. Fully integrated delivery systems will be measured across all 3 measure sets. And we'll plan to use the same performance assessment used by each measure set that we propose adopting. Next slide, please. So before we go into the details of each of the proposed measure sets, I want to share some sort of high-level advantages and limitations about our proposal. So one important advantage of adopting these measure sets is uplifting measure sets developed through intensive multi-stakeholder processes. Also, our quality and equity measure set would leverage existing publicly reported performance measure results and wouldn't add administrative burden to healthcare entities. It would also meet our statutory requirements to promote coordination and alignment between state departments, major public purchasers, and payers. And then also, we'll have the flexibility to collect a larger set of measures and can think about focusing on key measures down the line in our public reporting. So those are advantages. And then shifting to sort of considerations around limitations, there are some gaps. Each measure set includes a small number of behavioral health measures. Currently, the OPA healthcare quality report card measures for physician organizations aren't stratified by demographic characteristics, and that limits the equity analyses that we'll be able to do. For payers, performance results won't be collected or publicly reported by the DMHC for Medicare. Also, due to larger industry-wide challenges, physician organizations' performance results aren't publicly reported for commercial PPO, Medi-Cal, and Medicare fee-for-service members. We go to the next slide, please. Okay, so in the next several slides, we'll review each of the proposed measure sets that we're considering adopting that will together make up our quality and equity measure set. So this slide provides background on the DMHC health equity and quality measure set. So Assembly Bill 133 required the DMHC to establish and convene a health equity and quality committee to recommend a health equity and quality measure set and benchmarks with the goal to address longstanding health inequities and to ensure equitable delivery of high quality health care across all market segments. The committee was comprised of consumer representatives, health plan representatives, providers, quality measurement and health equity experts, and representatives from state agencies. Based on the committee's recommendations, the DMHC established the health equity and quality measure set and measure stratification requirements effective beginning measurement year 2023. And the DMHC may reconvene the committee to reevaluate the effectiveness of the health equity and quality measure set and measure stratification requirements. The payers subject to reporting to the DMHC on this measure set are all commercial and exchange market segments, including the individual, small, and large group markets, and the Medi-Cal managed care program. We can go to the next slide. So this table displays all of the measures in the DMHC health equity and quality measure set. So it includes cancer screening measures, patient experience measures, measures for chronic conditions, child and adolescent well care visits, immunizations, and other measures. And the asterisks on this in the table on some of the measures indicate the measure results that are stratified by race and ethnicity for measurement year 2024. And I'll speak to this in a little bit more detail in our equity analyses section. Okay, we can go to the next slide. Okay, so this slide provides background on the next measure set that we're proposing adopting to make up our quality and equity measure set, and it provides background on the OPA healthcare quality report cards for physician organizations. Assembly Bill 172 created the Center for Data Insights and Innovation, or CDII, by merging 4 committees and offices, including the Office of the Patient Advocate, OPA. CDII is now responsible for OPA's statutory mandates, which includes publishing report cards on healthcare quality. OPA's healthcare quality report cards are public reports that rate physician organizations on quality, patient experience, and total cost of care to help consumers make informed decisions about their health care. Quality ratings for the healthcare quality report cards come from the Integrated Healthcare Association's, IHA's, Align, Measure, Perform, or AMP program. The Integrated Healthcare Association's Technical Measurement Committee serves as an advisory body for OPA's healthcare quality report cards. The committee is comprised of representatives from health plans, physician organizations, and healthcare purchasers. The physician organizations included in the healthcare quality report cards are those who voluntarily participate in IHA's Align, Measure, Perform commercial HMO and Medicare Advantage programs. So the limitation that I mentioned on the last slide about our overarching considerations for the measure set, there's a gap in the available performance results for some physician organizations. So there's no publicly reported performance for commercial PPO, Medi-Cal, and Medicare fee-for-service members in the OPA report cards. We can go to the next slide, please. Okay, so this slide, the table on this slide lists all of the measures in the OPA healthcare quality report cards. It includes cancer screening measures, child and adolescent welfare visits, immunizations, controlling high blood pressure, diabetes measures, among others. Oh, this isn't the right slide. There we go. Thank you. Okay. All right, so moving on to measures for hospitals. So on this slide, we'll provide background on the HCI Hospital Equity Measures Reporting Program measure set, which is the set of measures we're proposing adopting for hospital performance measurement. So Assembly Bill 1204 required HCI to convene a Healthcare Equity Measures Advisory Committee to make recommendations on the development of a hospital equity reporting program to collect and post annual hospital equity reports that include measures on patient access, quality, and outcomes by race, ethnicity, language, disability status, sexual orientation, gender identity, and payer. The committee was comprised of representatives from academic institutions focused on healthcare quality and equity measurement, associations representing public hospitals and health systems, associations representing private hospitals and health systems, organized labor, organizations representing consumers, and organizations representing vulnerable populations. And so based on the committee's recommendations, HCI is finalizing the Hospital Equity Measures Reporting Program via the regulatory process in early 2025, early next year. The committee will reconvene after the first year of reporting to make a second set of recommendations to HCI regarding the submitted hospitals' health equity plans. And so hospitals subject to reporting on the HCI Hospital Equity Measures Reporting Program measures are licensed general acute care hospitals, including children's hospitals, acute psychiatric hospitals, specialty hospitals, and hospital systems with at least 2 general acute care hospitals. Next slide, please. So in this table are all of the measures included in the HCI Hospital Equity Measures Reporting Program. It includes structural measures and core quality measures across different domains, including maternal health, readmission rates, patient experience, and others. The asterisks indicate the core quality measures that will be stratified by race and ethnicity, age, sex assigned at birth, expected payer, preferred language, disability status, sexual orientation, and gender identity to the extent that the data is available. Okay, so we're back to sort of our overview slide that we showed before. And what we're going to do next is share more detail about our proposal to adopt sort of the full measure set for the DMHC measures, a subset of the measure set of the measures from the OPA report cards, and then the full HCI hospital equity measures reporting program set. So we can go to the next slide. Okay, so this table shows the overlap between our proposed measures for payers and physician organizations, and then the table on the next slide will show the measures for hospitals. So the first four measures that you see listed in this table align across all California state departments and apply to payers and physician organizations. So this is childhood immunization status, colorectal cancer screening, controlling high blood pressure, and glycemic status assessment for patients with diabetes. And of note, DHCS, Covered California, and CalPERS include these four measures in their programs with financial accountability for payers on quality and equity performance. And then, another thing that you see here is that we have like fewer measures for physician organizations than payers. You can see it in the green bars to the right on the table. We anticipate that the payer and physician organization measures that we propose should become more aligned as more measures are added to the OPA healthcare quality report cards. So the Integrated Healthcare Association is testing the depression screening and follow-up measure, the prenatal and postpartum care measure, and the well child visits in the first 30 months of life measure at the physician organization level, excuse me. So we expect to see more alignment over time as more measures are added to the OPA report cards. IHA is collecting baseline results for these three measures for measurement year 2024. These measures could be adopted for public reporting for measurement year 2025, depending on the evaluation of the measurement year 2024 baseline results. Okay, next slide, please. Okay, so this table shows the measures for hospitals, which include all of the measures in the HCI Hospital Equity Measures Reporting Program measure set. In the table, you can see which measures are required by hospital type, including general acute hospitals, acute psychiatric hospitals, and children's hospitals. Okay, next slide, please. Okay, so we mentioned in the sort of advantages section on the consideration slide before, although we're proposing to adopt these broad measure sets, something that we can consider is having a broad set of measures that we adopt and track, but then have sort of a smaller number of measures or key measures that we highlight in our public reporting. The one purpose of our quality and equity measure set is to monitor changes in quality and equity as healthcare entities work to meet the spending growth target. And in our public reporting, we can explore highlighting a subset of key measures that are particularly important to the goal of improved affordability of healthcare while maintaining quality and equitable care. Next slide, please. Okay, so now we're going to transition to focus on the proposed equity analyses that could be part of the quality and equity measure set work that we do. Next slide, please. So we'll start with payer equity analyses. The main equity analysis will be stratifying performance on quality measures by demographic characteristics. We'll align with the stratification requirements and reporting used in the DMHC's health equity and quality measure set. Payers must report to the DMHC aggregate measure results for all measures and measure results stratified by the NCQA, National Committee for Quality Assurance, for some measures. The NCQA has a health equity methodology for stratifying its measures by race and ethnicity. The NCQA currently follows the previous Office of Management and Budget, OMB, standards for race and ethnicity, which are shown on the table on the right on the slide. As many of you, I'm sure, are very familiar with, in March 2024, the OMB issued revised race and ethnicity stratification standards, which must be implemented as soon as possible, but no later than March 28, 2029. the DMHC will attempt to align future stratification requirements with the NCQA's implementation of these new OMB standards. Okay, moving to physician organization equity analyses, there are some limitations here. We mentioned this before. OPA's healthcare quality report cards don't include quality measures stratified by demographic characteristics. And this will limit the equity analyses that we can do for physician organizations. OCA will consider including additional population health analyses to supplement our equity analyses, and will continue to explore and assess options to expand our equity analyses for physician organizations in the future. Next slide, please. For hospital equity analyses, the main analysis will be stratifying performance on quality measures by demographic characteristics. We will align with the stratification requirements and reporting used in HCI's Hospital Equity Measures Reporting Program. Assembly Bill 1204 requires all core quality measures to be stratified to the extent that the data is available at the hospital and hospital system level. The numerator, denominator, and rate for all core quality measures will be stratified by the following categories: race and ethnicity, age, sex assigned at birth, expected payer, preferred language, disability status, sexual orientation, and gender identity. Okay, next slide, please. Okay, so in addition to adopting the equity analyses used by the measure set owners, we'll also explore including some additional equity analyses. We acknowledge that there are a lot of great health equity reports out there, and we hope that OCA can play a role in pulling information from some of these reports together in one place. We'll explore including analyses on population health measures by other state departments, California-specific surveys, reports, and social drivers of health, or SDOH indices, and national surveys to provide additional context for interpreting and understanding performance on the quality and equity measure sets. We may include key pieces from existing reports that are the most relevant to the quality and equity measure set and statewide spending growth target. For payers, we're considering reporting information from the DMHC Health Plan Demographic Data Metric, which tracks information on the type of demographic data payers are collecting and the percent of enrollees who they have that information for. At this time, the DMHC plans to collect the following demographic data: race, ethnicity, gender identity, sexual orientation, sex listed on original birth certificate, primary written language, primary spoken language, and disability status. The information collected will support discussions with the Health Equity and Quality Committee about new areas where stratification can be expanded to better track payers' progress where disparate outcomes may exist. We'll also consider reporting which payers have achieved NCQA Health Equity accreditation and NCQA Health Equity Plus accreditation. These programs focus on helping health plans reduce disparities, align their staff and leadership, become contract differentiators, and be recognized for their equity work. And then for all of the measure sets that we're proposing that OCA adopts, we'll consider adopting changes implemented by the respective departments, such as adding new measures or updating the stratification requirements. And overall, we'll continue to explore and assess options to expand our equity analyses in the future. Adopting the proposed quality and equity measure set is a starting point for us. We'll continue to work with sibling state departments and other partners to evolve these measure sets, collaboratively address the limitations we've highlighted, and strengthen our equity analyses. And I'll now pause for questions and discussion. We're really interested to hear your feedback on the proposal.
Great. I've got Samana. We'll go to Marielle, Travis, and then Sarah.
Thank you so much for this work and really valuable framework, and something that, is so near and dear to the work that a lot of us are doing every day. I just want to point out that from the ground perspective, the data is so complex to obtain. Like, actually having clean data is maybe the first part of that. And as part of our EPT grant process, we requested our race data this week, in fact, from our Medi-Cal managed care provider. And when it came in, it was so deeply flawed, and I've pointed this out previously to them. I had one family, same parents, 3 siblings, each one assigned a different race. So, we have age and we have address, which I don't see here. That is perhaps a valuable equity measure for you to look at, because when the data is not clean, it may allow for some, kind of double checking. And I know that so much can happen and is likely to happen over the next year or two to catch those kinds of issues. But we had over 20% of our patient panel assigned to a race that is very, very tiny, perhaps 1 or 2% of our local population. So the data, this garbage in, garbage out problem just is something we've been grappling with for a long, long time. And I wanted to bring your attention to that. I also was for an intense 3 days at the CMA House of Delegates this weekend, and the major topics were OB deserts and rural health. So there was a lot going on there in terms of equity, which took me to the AI and health panel. And it gave me pause. I don't mean to go off on a, I hope it's not a tangent for you all, but in discussing this, the term equity was used a lot, but there was general acknowledgement there that investment, appropriate investment in AI methodologies in every setting were critical, were exploding, and the people who were really sort of central in this discussion were saying, you can't really have parity here. There are disparities in healthcare, and those disparities will grow when we have these sort of efficiency technologies. I just wanted to mention that as well. Thank you.
Thank you. So we'll go to Marielle, then Travis, Sarah, Parker, and then virtually to Mike and Hector.
Thank you so much for this very detailed presentation and really telling us the story of how these different entities will be held accountable to measures of equity. I do have a few comments and questions, so I'll start with the smaller ones. So I know that we're all working to incorporate more disaggregated data on race and ethnicity, just kindly pointing out and reminding everyone Asian is really hard to quantify, right? In AAPI spaces, that's over 50 ethnic groups and over 100 spoken and written languages. So just another push for why this kind of data is necessary, because we know that there are some communities that are much greater in quantity than others, and that also impacts the disparities in health. Also pointing out that, for Native Hawaiian or other Pacific Islander, just a reminder that other is not a preferred identity across Pacific Islanders. I am also wondering, as far as other metrics that could be looked at, would it be possible in the future, or as soon as possible, to look at patients, clients who are lost to follow-up? We're talking a lot about continuity of care. Follow-up is a huge issue. We know that patients are lost to follow-up all the time for several reasons, some of it regarding a change in their health insurance, a change in employment as well. So all of that data, I imagine, gets kind of muddled up. So I'm wondering if that would also be a consideration. And then that would also involve who has employment-based insurance. I think that's something that is also worthy of looking at, because we know that access is a huge part of what we're talking about here, and we know that most people access it through their employer. And if they are accessing it privately, oftentimes they opt for lower tier healthcare options with high deductibles, which means they don't want to utilize it, right? Because they can't afford it. And then my last, sorry, I have a few more, gosh. I'm also wondering, I didn't see any metrics. I know that there's like child wellness, but, really concerned about domestic violence. I know that many of our communities, at least the ones I come from, and this is, we come from multi-generational households, and I'm wondering, right, and I'm not linking multi-generational households to domestic violence, but I'm wondering, right, if that could be something of use, because I know in our communities and when we collect this data, and even when we think about COVID, right, if you're living in a multi-generational household, you're more likely to contract COVID. That's just a fact, right? That's what we've observed. So I'm wondering if there's also initiative to include that. And my last point, and this is kind of like my point slash question with regards to behavioral health, so namely mental health and substance use disorder. Most people who would greatly benefit and who would qualify for behavioral health services don't actually seek them. And so my concern, and this is like in the area of like 95%. So my concern is if we are only catching a tiny proportion, I'm wondering if there are ways to better find that data through community-based practices. I know that the California Reducing Disparities Project is looking heavily into community-derived evidence-based practices, community-driven practices, to supplement what is happening on a clinical level. So a number of questions and comments. I'd love to know your responses to that and plans moving forward. Thank you.
Yeah, so really hear you on just kind of starting where you ended on the need for better ways to get at healthcare access. I think you're speaking specifically to behavioral health and like the, probably a huge percentage of people who have needs in that area but aren't getting those needs met or not accessing. And I think we've been thinking about healthcare access more broadly as an area that we need to figure out how to better get at it. And it's something that we really want to do more with in our equity analyses. So like we thought a bit about, in this proposal, what do we have around healthcare access? And I think on the payer side, the DMHC measure set has this getting needed care question, which we're really, glad is in that measure set with the CAPS measure. And that's for Medi-Cal and commercial plans. And exchange plans report on a similar patient experience measure in the Qualified Health Plan Enrollee Experience Survey. On the hospital side, the HCI Hospital Equity Measures Reporting Program is going to start to look at language access by reporting on percentage of patients by preferred language spoken. So we're seeing that as sort of like a key access thing on the language side for hospitals. And we're seeing gaps for physician organizations that we really want to do more thinking about how to fill. And then just like across the board, this is an area that we really want to look at how we could do additional equity analyses to supplement in that area. So that was the healthcare access piece. And then was there another question you had or piece earlier that you were looking for a response on?
Yeah, I appreciate that. I listed a lot of things. Just now I'm wondering about so I'll kind of circle back to what I had brought up that you haven't had a chance to address, but with regards to substance use disorder, behavioral health, mental health, would there be any kind of initiative? And I know, again, California Reducing Disparities Project is looking into it to include community-derived evidence-based practices, because we know that, a lot of us here have trained in research and academics, and yes, evidence is great, but we know that in certain circumstances, it's incomplete or altogether harmful in past reports, past findings. So, being of the community and representing the community, at least my community today, I'm wondering, right, if there is a way to incorporate the data that we collect or that we want to collect, that we want to have more ability to collect to supplement some of this. Because, for instance, when it comes to behavioral health, right, if you only have a small, tiny percentage of people who are actually seeking those services, then that doesn't really give us a good picture at all. Whereas there's a lot of work that community organizations are doing, but are not deemed, the gold standard of data, which is an equity practice in itself, right? So really wondering, is there a way that we can really expand healthcare? Because if we're thinking about what is health, what is well-being, what is being healthy, what is that, right? It's not just an absence of disease or comorbidity. We're also talking about like this ability to thrive. And I fear that, without enough understanding of how to frame a lot of the behavioral health and cultural pieces, that we're missing some really key data points that could really benefit these analyses and how we might move forward.
Yeah, thank you. I think on our end, we're really hopeful that over time we can include more behavioral health measures, and note that the committees for 2 of the measure sets that we propose adopting will be reconvening and looking at that over time, and that's something that we'll be tracking really closely and very much in support of and playing a collaborative role. In terms of improving the measures that we have, I think that's another area that we want to support on. And, so in terms of collecting additional data, I think you mentioned domestic violence or sort of additional data points or changing the way things are reported. I think we're seeing our role as collaborative with other state departments and public committees that are required by statute as a part of developing and adopting those measure sets. And so we really look to build and be a part of that work over time. Thanks.
Thanks. I have one more question, just following up to wrap things up. Is there a way for anyone here on this committee or, anyone moving forward to participate in, discussing metrics for equity in any of these, fields, whether it's hospital pay or physician groups?
Yeah, definitely. That's, we're really interested in discussions on that and would be very open to following up. Would really, it would be great for us. Yeah, thank you.
Yeah, I just want to know, we do have a Hospital Equity Measures Committee, Hospital Equity Measures Advisory Committee. CPEN has a seat on it. SCA, Joan just joined that group, and those like this are public meetings. So please do send in your written comments, give us your verbal comments. It's all very much appreciated.
Thank you so much.
Travis?
I had a question on hospitals who don't perform OB services or inpatient surgeries. How does that work on the quality measures?
So can you repeat the question?
So a lot of rural hospitals don't perform OB services due to low volumes and poor payer mixes. And I noticed those are quite a few of the quality measures. So how is that counted against us in these quality measures?
So I think, so we're recommending to adopt HCI's Hospital Equity Measures Reporting Program. The key thing with that reporting program is requiring hospitals to publicly post these equity reports, when in a lot of instances, it's a really big lift. And HCI will be providing technical assistance too, to get to the place of being able to report performance across these measures and stratified results. And so, but if there's, if there are specific questions, we're going to want to refer you to the HCI Hospital Equity Measures Reporting Program, because we're going to be getting the data from them, but not administering that program. But I would guess that if a measure is not applicable, it's not applicable.
Okay, that's what I was wondering.
Yeah, we can follow up to get specific clarification about non-reportable measures.
Thank you. Sarah, then Parker, Mike, Hector, and Carmen.
To me, that's exciting that we can maybe get more involved in, especially the mental health and substance use disorder equity and quality measures. And because you had mentioned that there's very little that exists, in your proposed draft at this point. And I noticed the depression screening and follow-up on there. And I mean, I know that is just way too narrow to have a comprehensive idea of the quality and equity going on in the provision of mental health services and substance use disorder services. I mean, this is an anecdotal example, but when I worked for Kaiser, one of the things that we would do is we would have therapists that they they only saw people who screened positive on these depression screenings through the primary care doctor, and they had better access than the rest of the clients who would call in, because that was one area that they were going to have to report the data on. And so when the screenings are too narrow, it kind of tends to maybe skew decisions made about who gets care, who doesn't, or who gets timely care and who doesn't. So it doesn't really reflect the true access issues. The other thing I was thinking about is both the DHCS and DMHC, they both require collection of data about timeliness of routine and urgent mental health appointments, and the use of those clinical specialty associations or nonprofit measures to determine level of care, especially to demonstrate like if there's a denial of residential treatment. And I'm wondering if some of that data, or, you know, my impression is there's issues with the data that's collected, but if that kind of data, since it already is something being focused on or collected, if that could be pulled into quality and equity measures. And one measure that I always thought about when I've been working, I mean, I still work at Solano County Behavioral Health, is the cultural and linguistic appropriateness of treatment. And that is, you know, by state law, SB 855, a requirement, and a requirement that out-of-network care is provided if we can't provide it in-network, that kind of culturally appropriate, linguistically appropriate care. But there's no tracking of that. And if there was a way, just like tracking timeliness, tracking is the person being linked to or referred to that kind of appropriate care. And to a little bit building off of one of the points Marielle made about a large portion of people who aren't even seeking out care through our you know, our kind of mainstream model through our medical system. I believe that that is absolutely true. And it's also true that the people who do seek out care, they aren't getting the care. Even at my current workplace, you know, Medi-Cal, uninsured, Medi-Medi, homeless on the streets, mental illness, substance use disorders, they, you know, go through an assessment with me and get told, you'll be called. They're put on a wait list for care. So we have a long way to go to even serve the people who are currently seeking care. Yeah. Thank you.
Thank you. We'll go to Parker and then Mike.
Thank you very much for your work, and this is exciting. So most of my comments relate around kind of the quality side for right now, and not just from a physician representative here, but specifically a family doc, and specifically one who works in FQHC and deeply embedded in preventive and primary care, which we often refer to as both the bane and the pleasure of our existence. And the bane part because it's something we focus on and have to report and think about every single day. And because for many of us, the measures that you've in fact listed here are great, and I love to get good scores and see green columns, but they often miss, for us, what we always say, what is the essence of what we're doing? I'm going to touch on that in a second. When I look back at those measures, specifically referring to that page 48 kind of the physician and the payer summary, those are a great list. Those are things that I'm working on every day in my clinic. And the first point is to illustrate that those are largely exactly what I capture in a primary care clinic. They are missing all the other outpatient physician data gathering. So there's very little there that we aren't reporting. So that's just one comment that really when you're saying quality or capturing that, that's all primary care stuff. And we all know we're trying to make primary care more important and preventive services. That's great. This to me emphasizes how critical or where that data is. The second comment here I'll make is more of a clinical commentary about these. I look at these and I say, okay, this is great for me in my clinic. I do want to know what percent of my patients have colorectal screening. When I'm looking at statewide data, my thought is I don't know what value reporting that directly is on like a statewide value. My comment recommendation would be to think about these in buckets. And I look at this and say, well, there's a preventive care bucket that would, to me, include colorectal, breast, and pap smears. You could throw in a couple others that you debate whether you want to throw in childhood immunizations. You put those together and say, overall, how are we doing on those together? That gives some idea of what is a preventive care approach doing in our population. You could do that as well with the pediatric care and just say pediatrics, let's combine childhood immunizations and well child data kind of together and say overall, what's that looking like? You could do that in adult care and say combine both glycemic status and kind of some of the other measures that you've hinted at and blood pressure, because tracking to state level those individually I don't think is your goal. It's to say, how's adult medicine doing? And since hypertension and diabetes are the two most common adult diseases we deal with, putting those together and saying overall, how's that percentage seems to me to conglomerate and potentially be a more productive measure. And then certainly you could do that with behavioral health. The final comment I'll make hints back to when we talk about the bane in primary care, what we say is what these quality measures for us always miss is what we call the secret sauce. And I know that's hard to measure and that's not purported anywhere. So this is kind of my fantasy wish comment. Like, how could we, this is great, and I'd like to leave it with the push or the fantasy wish to how do we get to that point of what are we really doing? And we're really trying to say what the goal of HCAC and all of this group is involved in making healthier Californians. How do we really measure, is all of this that we're doing producing happier, healthier lives in the long run? And that I'll sum up by just saying, last time when we were giving input, we talked about trying to get to that simple concept. One, by keeping these as simple as possible. And then two, and I think it was Hector Flores who mentioned saying one question that he uses or he thinks about is the one clinician question, the question of, can you identify your primary care home or your primary care clinician as some type of rough beginning measure of, are we in the primary care space establishing this notion of continuity? Because we do know very well that the greater the continuity over time produces improved healthcare outcomes. That is hard to measure on a year-to-year basis. But that's my plug for a quality measure called secret sauce.
Thank you, Parker. We're moving online. Mike O'Day, would you like to go ahead?
Hi, thank you. First of all, thanks for the presentation. I had two questions. One, was there any consideration of dental measures, and did you all consult with the State Office of Oral Health? My second question, I was looking for clarification on age stratification. I see it in the hospital equity analysis, but I wasn't sure if it was part of the physician equity analysis, and I think there's a couple measures like depression screening and follow-up and asthma medication ratio where we'd want to know how we're doing for kids and adolescents versus adults. Thanks.
So, Mike, this is Margaret. I'll just jump in on the dental piece. Is that, we framed our look at the proposed measure set based on how OCA is measuring total cost of care, which is focused starting on payers and then looking at fully integrated delivery systems and hospitals and physician organizations. So we have not included any dental measures. We could take that back if that's of interest and consider that further. And then Jana, do you want to jump in on the measure piece?
Yeah, so I think the measure question was stratification by age. So we don't have that on the payer measures, like you mentioned. That's included in the HCI Hospital Equity Measures Reporting Program stratification. In terms of particular measures, though, like the depression screening measure that you mentioned, that we're recommending adopting for payers and physician organizations. That's for adolescents and adults, so that'll be like built into the way the measure is reported in terms of the denominator. So I hope that answers your question.
So it'll just like on the depression measure, it would just be one rate. It wouldn't be broken out sort of by adolescents versus adults at in any sort of reporting.
The depression screening and follow-up for adolescents and adults, there are two like parts to that measure. It's depression screening and then follow-up on a positive screen. I think we may need to look into whether we can get a breakdown for adolescents versus adults. It's a great question. Thank you.
Thank you. We'll go to Hector and then Carmen and then Karen.
Yeah, thank you very much. Thank you for the presentation. I join others in thanking you for that, and also trying to crosswalk multiple agencies and organizations trying to address the equity issue. So a couple of things. Many of us are moving to patient self-designation on race and ethnicity, as well as sexual orientation, gender identity. And I like that you're also collecting sex assigned at birth to see how that changes over time. But it will take time to be able to get at the right collection of the right data. In particular, those of you who are familiar with Dr. David Hayes Bautista at UCLA, he's been doing a lot of work on what he calls racially ambiguous babies, looking at California birth records for the last 20 years. And the last couple of years, almost, or actually over 40% of new moms are designating their babies under multiple racial and ethnic groups. And it really starts to blur the lines around what we intend to do with this race and ethnicity data. So something we need to keep in mind. And the second part is where do we put socioeconomic status? We kind of use Medi-Cal eligibility as a proxy, but we know that there are folks that are $1 too rich for Medi-Cal, but they're still poor. And secondly, some may have commercial insurance through work, including some of the undocumented population. And we may be making assumptions that because they have commercial insurance, they don't have a lot of the same disparities that others do. So just really something to think about as we begin to sort of refine our methodology. And then to add to that mix is, many of us are collecting adverse childhood experience data, as well as social drivers of health, using tools like Prepare and others. And we're going to need to figure out how to value that data is being collected and how to put it to good use as we look at equity metrics in the future. And then something that Dr. Reddy talked about was, not only OB deserts, and Travis's question is very apt, appropriate for that, because at White Memorial, we're starting to see some hospitals around us closing their labor and delivery units. And we're starting to see patients traveling longer distance to get to White Memorial to deliver. And it's going to skew the data in terms of outcomes and all the issues that we're looking at. The second thing that I'm noticing talking to pediatricians is that we're probably going to be talking about pediatric deserts in the near future. Pediatrics has tended to consolidate around academic medical centers and children's hospitals. There are large organizations, like Kaiser, Optum, and others that are also recruiting pediatricians. And then FQHCs tend to be at a disadvantage because they often lose their providers to these larger employer systems. And what I do see is that there are fewer and fewer pediatric independent practices, in part because of the Medi-Cal payer mix and the fact that they're having trouble having sustainable practices. And that's why I support Prop 35, because, I think it'll bring some parity and stability to their practices and stability of access to the patients. So I think we also need to be aware of those deserts that are coming our way. And certainly rural health is a desert in itself that we need to be conscious of because of the distance that patients have to travel if they get the care at all. So I think this is great work, but we need to make sure that we're including all these variables that otherwise will confound our intent, which is to really reach what equity means for patients and what we need to do to represent their interests. So someone made a suggestion to have a committee. I think a committee that would look at maybe one or two measures rather than reinventing the wheel with what others are doing. But look at one or two measures and make recommendations about how we should address those. I think it would be a good place to start. So those are my comments. Thank you again for the presentation.
Thank you, Hector. Carmen?
Yeah, I appreciate the conversation. I know when we discussed this or something related to quality and equity measures, we had talked about, making sure that, looking at quality and equity measures don't disadvantage, small practices like Sumana's, like Parker's that may not have the ability to game some of the metrics like many larger health systems do very frequently. And I think we want to make sure that when we're talking about the outcome of a statewide report of performance improvement plans, that this doesn't inadvertently disadvantage very important types of providers that need to provide primary or rural healthcare services, because we know that there are health systems, there are hospitals, like Hector was talking about, that are closing OB services, that are closing pediatric services for the purposes of reducing spending and costs to and cutting on their revenues. And I think that's really an important thing to recognize here, is that the value of looking at equity and quality measures is to understand where the gaps in access are, where there is inappropriate cherry picking or lemon dropping of high cost patients. And I think that's really where I see the value of looking at these measures, rather than kind of reinventing yet another value-based payment, which just incentivizes higher cost uninsured, people with certain types of payment plans being shoved out of our healthcare system. And I think that's really important for us to look at when there are future, whenever reports come out. I think at least some sort of regional analysis would be really important. In the Inland Empire, there's a hospital that is trying to close its OB unit tomorrow. It's really important to understand these trends in terms of what is happening with healthcare service closures, what's happening with mergers and acquisitions. Children's Hospital of Orange County and Rady's Children's Hospital are about to merge. What is that going to mean in terms of access and quality of care? Rather than kind of just repeating the idea that the way that we get better performance is by looking at cost, and payment structure. I think that's something that OCA can look beyond. I know we've talked about this a lot. I am not a supporter of value-based payments because of a lot of the unintended consequences that can occur. So, it shouldn't be surprising that this is a really big concern for a lot of folks. But anyways, I think we really should look at what it means to implement through performance improvement plans. It gives me great pause because I don't really understand what the goals and the outcomes of this exercise are, and really trying to make sure that what OCA is doing in their analysis of existing data on quality and equity turn into something that can actually be usable in terms of ensuring that healthcare resources are getting to the right places, that we're filling the gaps, whether it's through state programs or other types of mechanisms to ensure that people have the healthcare services that they need. Parker's secret sauce, that is what we're trying to figure out here, is how do we make sure that we're getting healthcare services to the folks that need it and the folks that have been, have had trouble accessing healthcare in our state.
Carmen, I just want to address the point about, what exactly are we trying to do here? And so, several of us are in the room that worked on the law, and the specific issue with the quality and equity is, right, all along, this is not about just a low value healthcare system, but really a high value system. And so the purpose is so that as we're measuring the spending growth targets and the spending growth trend, we're also looking at equity and quality, because we don't want to negatively harm our quality measures as we move forward. So, you know, we did have a lot of input on these measures when they were initially adopted by the entities that adopted them. We had a lot of input from the investment and payment work group. Now we're getting your input, and we're going to have to, you know, have as simple a way to present the data to have it be meaningful. You know, to Parker's point about like all these individual measures, how do we sort of group them so that we're looking at them over time? So we are thinking about that.
We'll do Kieran, Stephen, Joan, and then we'll wrap up this agenda item.
Thanks, and I'm glad you just said that, because that's where I was going to go. It's sort of, you know, let's step back, and, you know, for us, the thing here is we sort of can predict what health systems might do left unchecked when told they need to rein in cost growth, right? And who could be negatively impacted by that. And so this is supposed to be the counterweight to that, right? And so with that kind of in mind, I do think this is a little complicated. Like, I think it's going to be hard to look at all those measures and say, well, hang on a second, we see this happening, and so, you know, we think health systems might be restricting access for this population in order to reduce costs. Like, it just seems like almost too much data to be able to do that. So I do think there's some nice overlap and alignment between metrics across the three programs you talked about, which is going to be really helpful. I will also say, you know, we were part of the DMHC committee, and I think our sort of overarching takeaway from that is that it did, to a certain extent, not do what we needed from an equity perspective. And I think, you know, part of that was leaning really heavily on the NCQA health equity accreditation to sort of fill in that gaps. And so I'm glad we're talking about reporting that, but it still won't be required, right? And so I do think on the plan side, it would be important to go back and look at some of the process measures or structural measures as you have done on the hospital side. I think that's missing from an equity perspective, and even things like access to interpreter services, right? That's one place I could see, you know, health plans saying, oh, we're gonna do less of that, right? So I think it's those kinds of things that we really want to also make sure we take a look at. I will also just point out for DMHC, there's no stratification of the access measure. And I know we talked about we're leaning sort of heavily on that measure, but there's no, to my understanding, there's no demographic stratification of that measure. And so that's going to be problematic. I also think on the health plan side, it's going to be important that we're looking at the lines of business and doing that comparison, as well as, to Sumana's point, I don't usually advocate for sort of the place-based, but I do think this is an area where it probably would be good to look at that data and do that overlay with the Healthy Places Index or something like that, so that we can identify, right, where are we seeing care potentially reduced, and we need to follow up on that and sort of push back on that. A couple other things, I think from the physician organization, so that seems really like a weak spot because there's just not that much that's collected and measured through that program. There's a lot of populations that are missing. There's no stratification. And so I do have a question about, can we supplement that through the health plans? Can they report on physician organizations more aligned with the data that they're reporting overall? Like, is there something we can do to supplement that? Because that just seems like such an important component of this, and that program really doesn't give us a lot to work with. And then the final thing I say, I do think there's some vulnerable patient populations that, you know, are always sort of at risk of being mistreated and underserved by the healthcare industry that are missing from this, and that would be older adults and people with disabilities. So I wonder if there's anything specific, because I think we also see that as an area of real opportunity for reducing costs through better quality community-based care, right? But I don't know the extent to which we can measure that. So I guess my overarching point is it'd be helpful to figure out how these relate to the goals and really thinking ahead to what are some of the ways in which we might see the adverse impacts that we're trying to prevent, and more target the measures and the specifics to that.
Thank you, Stephen.
A few suggestions quickly. One, in terms of the quality measures that are shown, particularly the hospital ones, is to note which of those are risk adjusted. Are they all going to be risk adjusted? Many of them will be. So just to make that clear to people that we're looking at risk adjusted quality. And that may also apply to some of the provider organizations as well, although it's more relevant for the hospitals. On the hospital measures, there's only one maybe patient safety, and this is a more general suggestion to see what the group thinks. When we talk about quality, most of us, I think, embed within that patient safety, but increasingly I see in the literature quality and patient safety. And it's just something for OCA to consider in terms of what language you use around quality and patient safety, and maybe breaking out patient safety to know that, yes, it's a dimension of quality for sure, but it's getting so much attention now. About 25%, or at least 1 in 5 people hospitalized in the United States have an adverse event. About 33% of those are serious. 43% of those are preventable. Okay, this is in the published literature. And I think, I could be wrong, that California has a patient safety organization or an entity of some sort. And so I'm wondering, you know, if there isn't some reliable data available on things like sepsis, hospital-acquired infections, falls, ulcers, never events, and so on. It's just something to look at. It may not be ready for prime time yet, but it's something, you know, to certainly consider. A couple of other points. Parker, I think, hit the nail on the head. Composites, and you guys know this. I mean, you know, how to aggregate these up so they're really meaningful, and where the levers are going to be in terms of the ultimate goal of making sure quality is safe while we're trying to reduce the rate of growth in spending. And I had, well, offline or whatever, can make some suggestions in that regard. Dr. Flores mentioned social determinants of health screening, and I was a little surprised that those aren't in there. They are for hospitals, I saw, but not on the physician side, maybe because OPA isn't there yet, but they're pretty common now. You screen, right, for food insecurity, for housing, transportation, domestic violence. The core 5 are there. And there's actually I think they're almost ready for prime time. And maybe we need to push OPA a little bit, and also in terms of why aren't they stratifying? You know, let's understand how they can be helped maybe to do that. There may be good reasons they're trying to work on, but that would help as well. And the last couple things quickly is in terms of subset of measures, again, to this point, which ones are going to be the gold nuggets, right, of all the data we're collecting here. It'd be interesting to think about what criteria are you thinking about in making those decisions? And is it going to be the number of people affected by the measure getting care in California, the opportunities for prudent cost reduction, right? Where are the opportunities for that without harming quality? Or indeed, in some cases, maybe by reining in costs or inefficiencies, you can improve quality. Because some of the things we do to people, we don't intend to, but they have adverse effects as well. And the final suggestion or comment, I would definitely encourage you to report which payers have received NCQA Health Equity Accreditation and Equity Plus accreditation. Make it visible from the beginning. Get it out there. Appropriate footnotes of, well, this isn't perfect yet, and we only have it for 300 and not 1,000. But get it out there because it creates that visibility and people begin paying attention to it.
Thank you, Joan, and then Tam, and then we'll wrap up.
Adding on to, I completely agree on the physician organization comments that have been made, that that does feel like the weak place in this, and recognize that that's just where the data is right now. One thing that I haven't heard mentioned is that there's not a perfect mapping between the definition of physician organization and the OPA list. OPA only reports quality report cards for about 200 physician organizations, and so it would be very helpful once we have a better handle on what is the universe of physician organizations that will be reporting and are subject to OCA, where's the mismatch there? Because my strong suspicion is going to be that even that mismatch is going to be a quality and equity issue. That the medical groups that don't have an HMO contract, which is basically a commercial or Medicare HMO contract, which is who's reporting under OPA, those medical groups are going to look fundamentally different than medical groups that are and are not. And that's going to be particularly true for some specialties. And it would be helpful to start understanding where we don't even have a starting place.
Hi, I was wondering if you could speak to and help connect the dots here. So are these measures for the hospital measures, the AB 1204 measures, will these be the only measures that OCA will consider when evaluating, whether a hospital meets the target in a way that doesn't erode, quality and equity, or will there be additional measures or benchmarks that would be considered in that process? And then I just wanted to comment, and I appreciate the work that the AB 1204 work group has done, and I just wonder if these measures are, whether all of these measures are the best measures to be used in the context of OCA and in terms of, cost containment and affordability and access and equity. And I think, some of the structural measures here don't actually speak to whether a hospital actually attains or improves quality and equity, like the measures around designating an individual to lead health equity activities. That's like a yes or no, get a question or measure. Documentation of policy prohibiting discrimination, reporting the percentage of patients by preferred language. And so I think I just encourage OCA to look at additional ways of evaluating, some of these issues, but I think, some of these structural measures might be more limited there. And then the last comment, I think echoing what Travis had mentioned earlier, is that a lot of these measures are not going to apply to hospitals that don't offer certain services. And so I think that's also an area where it would be helpful for OCA to look beyond the AB 1204 measures.
Thanks for that feedback. Yes, certain measures may be non-reportable for certain hospitals that don't offer certain sets of services. And we're looking at the HCI hospital equity measure set as a starting point for how we look at hospital quality and health equity. And so, like others have mentioned, there are other hospital measures that we might look into to supplement this. So we're happy to look into that further and come back to you all with additional thoughts and welcome any further recommendations.
Yeah, I wanted to return to Joan's question earlier. So was the question like about commercial PPO medical groups? Is that what you were referring to?
Well, I did a couple quick spot checks of medical groups I know exist, and they're not in the OPA list. And OPA is very upfront. There's an entire section on their FAQ of why isn't my medical group listed. And so they are very upfront and aware that they're only capturing a subset of medical groups. And it would be very helpful to know what that universe looks like.
Okay. Yeah, we're HCI is working on kind of cataloging the universe. It will take some time, but kind of there are also some issues to work through, whether the medical groups that aren't listed, they typically tend to be PPO based contracts, and kind of there's a larger set of challenges there with kind of they don't have the same like a panel of patients in the same way that a HMO based contract does. So it'd be difficult to report on those, or we'd kind of have to see what could be done in that space.
Yeah, even if it's not attempting to get them to report quality and equity, literally just what do they look like? Are we missing, how many medical groups are we missing? How many physician organizations? Are we missing a huge chunk of certain specialties? For example, behavioral, we know that there's a challenge with behavioral health groups not contracting with HMOs. So are we missing a huge chunk of the behavioral health physician organizations? Just understanding, because if we're saying this is sort of the quality and equity measures for hospitals, we'll have really good coverage. For plans, we'll have really good coverage. And just on physician organization, it's understanding what are we even looking at, rather than necessarily saying, okay, everybody who's not reporting to us, the patient advocate, you now have to report something. Let's start with just what do we not know?
Thank you.
I also just wanted to go back, Tam, to your question about are the hospital equity measures the only universe that we'll be looking at, and also are some of them best equipped to do what we're trying to do with the law? So as to the latter one, please give us your input. So, I mean, you all know you can send us written comments and the like, and obviously you know that. But so I hear the point on some of the binary, like yes, no questions. That's hard. It's not like we're going to be tracking that in the same way over time. So we'd love your input. But as to the first question, yeah, I think this is the universe that we're looking at. But again, if you have a different perspective, let us know that.
All right, that concludes discussion on this agenda item. We are ready for public comment. If you'd like to make a comment, please step to the podium, or online, raise your hand. Please limit your comments to 2 minutes so we can hear from as many folks as possible. I will, looking virtually, seeing no hands raised at this time, we'll go to the podium.
Beth Cavell for Health Access. At the risk of standing between you and lunch, a few comments. First of all, happily, the law says that the quality measures, the priority measure set, will be annually reviewed and updated. So as important as it is to start off doing something well, it's not your last chance. Secondly, I want to commend Director Landsberg's comments. The presentation speaks about the goal of improved affordability while maintaining quality and equity. The law speaks about promoting quality and equity. And I think it is that larger goal of the triple aim of trying to lower costs while improving outcomes and improving equity that we should be speaking to. A couple other quick points. We wholeheartedly agree about income being an important measure in Medi-Cal, not being a sufficient measure of low-income population. We also agree that patient safety measures in hospitals are important. California's been, Steve Shortell is correct, in collecting information on never events for 20 years. And happily, sometimes now we actually have hospitals that have 0 of those, which is a good thing. And the place we want to be, rather than the place we were where the hospital said there was no way to prevent never events. So that's an important measure set that CDPH has. With respect to 2 other, I would say, less than satisfactory measure sets, we were part of almost all of these quality measure development efforts. The lack of behavioral health measures is really troubling. There just aren't very many good ones that count as recognized measures. This is a failure of NCQA in the national measurement effort, and one that we noted in the DMHC process in particular. We are very pleased that at least there's depression screening, because the traditional measure is medication, which is not always the appropriate treatment for depression. So we have advocated for depression screening and follow-up as a very modest and minimal step. Finally, with respect to the Office of Patient Advocate, it was part of the HMO Patient Bill of Rights, which we sponsored in the 1990s, but I think it bears the hallmarks of being 25 years old. And unfortunately, relying on IHA, which doesn't include the kind of diverse participation that's present here today, including consumer voices and communities of color, because otherwise they would be stratifying those measures. So sometimes things need updating. It's good the law on this says that you should update annually. I only wish some of the sources you were relying on were doing this.
3 minutes.
Thank you.
Looking virtually, seeing no hands raised, noting we have roughly 51 virtual attendees at this time. Going back to the podium, please go ahead.
Hi, Justin Ziambra, California Hospital Association. Thank you for the chance to comment. Just had a few brief points. First, hospital equity regulations are not yet finalized. As constructed, these regulations will require increases in the breadth of data hospitals are collecting. As noted during the conversation following the presentation, this will take some time and would hope that OCA in turn provides for the appropriate time runway in its considerations. Second, improvements in quality require significant investments. It's not enough to simply monitor performance on quality metrics. The office must also do the work of understanding how much it costs to make improvements and must consider these investments in its evaluations. Third, quality metrics require evaluation from both an improvement and attainment perspective and would urge the office to consider both dynamics. Fourth, we appreciate that the office is statutorily required to pick a measure set. However, when it comes to evaluating the effects of the spending target on quality and access, would insist that in those instances where a provider has violated the target, that quality and access are evaluated more holistically. And then finally, we have some specific concerns on the individual measures, and we'll be following up with written comment when that opportunity presents itself. So thank you for that.
Thank you. Continuing public comment, seeing no hands raised virtually, seeing no one at the podium, that concludes public comment on this item. The time is now. It's time for lunch. All right, the time is 1:03. We will return at 2:05. Welcome back. If you could just make sure your microphone has a red light on it, so we're not projecting. We will go ahead and get started. The time is now 2:06. We're moving on to agenda item number 5. I will turn it over to Assistant Deputy Director CJ Howard.
Good afternoon, everybody, and welcome back from lunch. I will attempt to be brief in this, but I am just going to be giving a brief overview of some of the high-level proposed changes. None of these are finalized. We're socializing them both with submitters and with this group and with our board for broad input and feedback. And I'll walk through a timeline in just a slide or two's time. So if we can move to the next slide. I think we need to go 2 in a row here. There we go. So for the data submission guide, this is our data submission guide 2.0. 1.0, we just, as Vishal referenced earlier in the meeting, we concluded collecting that data in October from the submitters. And so we need some changes and updates, as we'll likely evolve and iterate on this for at least the next couple of years would be my best guess. 1 year at a time, though. So this will outline the requirements for submission of the data for the 2023 and 2024 calendar years. This will be submitted to us in September of 2025, and we will get a draft, a finalized draft of our proposed changes in early 2025, and the registration will remain the same for submitters, which would be May 31st of 2025, and then the submission in September. So if we could go to the next slide. Just these are the high-level overview of the changes. I'll cover the first 4 of them in a little bit of detail before handing it off to Margareta to dive more into the 2 new files that we're proposing for alternative payment model and primary care data collection. But at the top, one of our proposed changes is requiring licensed health plans and insurers to submit data separately. Currently, it's done at sort of the parent corporation level. Based on feedback from some payers and some of their health plans that have separate data warehouses, it can be easier for them to submit separately. This also allows for more accurate matching of payer submitted data to some of the other state and federal data sources that we're matching their data to, such as MLR reporting. And additionally, this allows for potentially more granular analysis of payer performance relative to the target and just payer performance overall. We're also proposing to remove the provider organization and tax ID list requirement from the 2025 registration. So in 2024, when payers registered, we also asked for a list of TINs associated with provider organizations. This was burdensome for the submitters. Our goal in doing this was to determine unique identifiers for defining provider organizations. And what we found across the payers is that a lot of the data was inconsistent. There were many-to-one and one-to-many issues with tax ID numbers. So while we're still interested in finding more unique identifiers for providers, and we may revisit this in the future, our next step on this front is to engage more directly with the provider organizations to get a better understanding of how we can create unique identifiers for the provider organizations that we can then use for attributing spend to the provider organizations. We also intend to remove the Los Angeles spas from the regional file and use the 2 covered California rating regions instead. Reasoning behind this is that OCA is not likely to report geographic spend down to the spa level. Using the covered California regions also standardizes data submission for payers across various state entities and can also enable more comparative analyses where we could use covered California data and compare our data against covered California data in their regions. And it's not that we won't be able to do more granular level analysis, but we think that the HPD may actually be a more productive environment for this type of more granular geographic analysis. Yeah. And then lastly for me is we intend to remove some duplicative fields in response to submitter feedback. For example, dropping the member responsibility from the attributed and the regional file. This would still remain, the member responsibility would still remain in the statewide file, and so we just didn't want to be collecting the same data elements in multiple files, and so this is just to sort of streamline the reporting process. So Margaretta, in just a minute, we'll get to the next 2 about the alternative payment model and primary care data files, but if we could go to the next slide. Just a high-level timeline for DSG 2.0 implementation. We will publish the final or draft revisions of the regulations in January. There would be advisory committee feedback and discussion January 21st. So we'll be coming back with what our final responses were on some of these, or final proposed revisions were. And then the board would discuss also in January of 28, and then we would submit the final DSG with all of the feedback and revisions in March or April. And then the revised regs would become effective in April and submitter registration in May. With that, we can go to the next slide, and I'll hand it off to Margaretta.
Thank you, CJ. So in this next portion of the presentation, I'll walk through our proposed approach to data collection for alternative payment model adoption, and then we'll turn to primary care spending data collection. I'll start with a bit of background on each topic and then review more details related to the data collection approach. So just as a refresher, as described in statute, OCA focuses on 5 areas for promoting a high-value healthcare system alongside the spending growth targets. And our efforts to monitor consolidation. So, of course, across these areas, the goal is to reorient the healthcare system towards greater value. In this next section, I'll talk about, for APM adoption, how we will collect data to monitor alternative payment model adoption based on how the alternative payment model adoption goals are structured. And then on the next slide, just again, another refresher of our statutory requirements related to alternative payment models, which are to move more payments from fee-for-service towards alternative payment models, measure this movement of payments, set a goal for statewide APM adoption, which I'll recap in the next slide, and adopt contracting standards for providers and payers. So on the next slide, this recaps our alternative payment model adoption goals that were adopted by the board in June of 2024. So the board approved our APM standards and adoption goals in this meeting, And our proposed alternative payment model data collection approach is intended to track progress towards these board-approved goals. So there are a series of 2-year goals across 10 years that differ by payer and product type, and a final 10-year goal of 95% for commercial HMO and Medicare Advantage, 75% for Medi-Cal, and 60% for commercial PPO. And the goals are structured based on HCP land categories 3 and 4 and the percent of members in these payment arrangements by payer type. HCP land categories 3 and 4 are shared savings and shared risk payment models, and then population-based and capitation-based payment models. So the APM adoption goal is based on a percent of members in APM arrangements to encourage a focus on population health. Therefore, we will collect information on the number of member months in different types of alternative payment model arrangements. We also require that alternative payment models include a link to quality in order to count towards the APM adoption goals to ensure that affordability does not compromise quality of care. So in addition to collecting data on member months, we will also have an indicator to flag where payers will flag whether a payment is linked to quality or not. And of note, we aligned our goals to the national HCP land framework, the Healthcare Payment Learning and Action Network framework to facilitate comparisons to national data. And then we'll use the HCI expanded non-claims payments framework to better understand the purpose of payments made to providers. And I'll talk about the expanded framework on the next few slides. And to measure progress towards the goal for performance year 2026, the baseline will be established on 2024 data collected in 2025, and data on the 2026 goal will be collected in 2027 and reported in 2028. So that's the cadence of reporting, data collection and reporting. And the next slide, this describes how HCI will collect non-claims payment data, which includes alternative payment model data for primary care, APMs, and total medical expense, and at the Healthcare Payments Database, or HPD. So all except for the total medical expense data collection will report non-claims data using the expanded framework subcategories. The TME data collection will only collect data at the category level, and we'll walk through these in the next few slides. And to determine the portion of total medical expense flowing through different alternative payment model arrangements, OCA will collect data on all payments for the members in an APM, both claims and non-claims payments, into one subcategory. And this data collection approach will allow OCA to align with reported payments with the national HCP land data collection categories and make comparisons against national data, as I noted earlier. And then for all other data collections, we will request the actual non-claims payments by category or subcategory. And all of the data will be collected annually, and additionally, HPD will collect capitation data monthly. So if we can go to the next slide. This is a reminder of the HCI expanded non-claims payments framework. We've reviewed this framework in past meetings and just wanted to recap in terms of how we're using it to collect alternative payment model data. So these are the categories and subcategories A, B, and C, and then we have the next slide with the remainder and how they crosswalk to the corresponding HCP land categories. I wanted to note here that for episode-based payments C1 through C4, we are proposing to collect information on the type of episode, not just the dollars amount spent for that episode. So for example, we are proposing to collect, whether an episode is for a cardiovascular procedure or for an orthopedic procedure. So, and we can move to the next slide. So these are the remaining expanded framework categories and subcategories D, E, and F. Note that F will not be part or counted towards the alternative payment model adoption goals. And then, so just a note that we'll collect APM adoption data by these categories and subcategories by market category and by product type at the payer level. So if we can go to the next slide to summarize. So for the APM data collection, we'll collect alternative payment model adoption membership data by market category and product type at the payer level to monitor progress towards the APM adoption goals. We'll collect and report on APM spending data as a per member per month and as a % of total medical expense collected at the expanded framework subcategory level. And then we'll collect membership and spending in the episode-based care models by episode type and expanded framework category, subcategory level. So next we'll turn to primary care, and then we can open up for questions and discussion. So we'll just do, again, a brief bit of background on primary care and refresher on the primary care investment work. So again, primary care investment is one of our components of promoting a high-value healthcare system, and as we noted, we recently adopted a primary care investment benchmark. And on the next slide, this is just, again, a refresher and reminder of our statutory language that guides our primary care work. So we are directed to set a spending benchmark and measure progress towards this spending benchmark. And it also notes that measuring primary care spending must consider categories of providers, procedure codes, claims, and non-claims payments. And we've talked about the definition of primary care previously in some of our advisory committee meetings. So if we could go to the next slide. So this slide summarizes the primary care investment benchmark that was approved by our board earlier this month. So the board approved these two related primary care investment benchmarks as shown on the slide. And here to measure progress towards the first annual improvement benchmark, baseline for the 0.5 to 1% increase per year for each payer will be established on performance year 2024 data, which is collected in 2025. And then progress towards the first annual improvement benchmark will be assessed for performance year 2025 on data collected in 2026. And so we will both be tracking progress towards the annual improvement benchmark and leading up to the 2034 15% statewide investment benchmark. So if we could go to the next slide. So just as a reminder, this is our overarching formula for measuring primary care spending. We're looking at primary care spending by claims and non-claims payments, and the denominator is the total cost of care or total medical expense. So for the next few slides, I'll focus mostly on the non-claims payments section and how we'll collect data for that. The claims-based payments will be allocated to primary care using the definition developed with input from the investment and payment work group that uses a combination of primary care providers, services, and care settings to identify claims-based primary care spending. And those detailed code sets will be included in the data submission guide. So for the non-claims payments, again, we'll be using the expanded framework categories and subcategories to collect non-claims primary care spend data. And note that only certain subcategories of non-claims payments count towards the primary care investment benchmark, which are indicated in green. And for some subcategories, only a portion of the payment counts towards primary care spending. And so payers will submit non-claims primary care payment data for the expanded framework categories A and subcategories A through B and their associated subcategories by applying an OCA developed methodology to allocate portions of these payments to primary care. And this allocation methodology we've talked about previously in the advisory committee and will be specified in the data submission guide. And for category C, payments with shared savings and recoupments, only subcategories C3 through C6 include payments that count as primary care. Procedure-related episode-based payments, which are subcategories C1 and C2, are excluded from the primary care spending measurement because procedures and surgeries paid for under these arrangements are generally for specialty care, almost universally for specialty care. And a portion of condition-related episode-based payments can be allocated to primary care because some of these payments are for chronic conditions that may be managed in a primary care setting. So that's A through C, and then for categories D and E and F, we'll note here that payers will submit non-claims primary care data for subcategories D1, D2, D5, and D6, but not for 3 and 4, which are facility capitation and behavioral health capitation, as these payments are not for primary care. For professional and global capitation payments, OCA has developed a methodology in collaboration with the Investment and Payment Work Group to allocate a portion of those payments to primary care. And again, that methodology will be detailed in the data submission guide. And of note here, OCA is discussing with DHCS whether there are some Medi-Cal non-claims payments that may be apportioned to primary care in category E. And we continue to have that discussion with DHCS and aim to have some clarity on that alongside the data submission guide work. And of note, payers will not submit primary care non-claims data for category F, pharmacy rebates. So here again is the summary of our approach to primary care data collection. So the primary care data collection will collect claims and non-claims primary care spending by market category and product type at the payer level, by the expanded framework subcategory level based on OCA methodology that was developed in collaboration with the Investment and Payment Work Group, and collect behavioral health and primary care spend as part of primary care spending, such that some behavioral health services provided in a primary care setting are included in the claims-based primary care definition. So I'll pause here for questions for either CJ or myself.
Thank you. 2 questions. First is for CJ. I know that there's a gap in capturing PPO self-funded data. Can you talk about how that fits in this whole picture of the data extraction? I think the ERISA regulated, not regulated by the DMHC membership is, I think, is a challenge in terms of getting that data. Can you educate me on that?
Yeah, so Michelle, feel free to also jump in here, as I know you're well versed in this. So we do not have in our regulations an explicit carve out or an exemption for ERISA plans. That said, our regs do provide for basically the way that it's written is that if there's a federal preemption from you that you believe applies to you submitting or that is preempted under federal law, then it would not be submitted. But I think we also, in our now that we've collected the data, I think one of the things that we will be reviewing with payers is what was in and what was out of the data that was submitted.
Do you have any feel for, given who's currently submitting, what proportion of the market will be unaddressed or not captured?
I think that's something that we would have to get back to you on after we've had a chance to more fully digest what's been submitted.
Okay, thank you. And then I have a question for Margareta. I think it's page 73.
Sure, go ahead.
I just want to make sure is it possible to pull it up? 73.
73.
Okay, I just want to make sure I'm understanding the benchmark, the improvement benchmark. So if in the performance year, based on 2024 data, the baseline year, suppose an entity has 10% allocation to primary care, is the way I interpret this that the goal per year would be, say, in the first year, go from 10 to 11, Or does 1% mean 10 times 1%, which would be 10.1% would be the goal? I'm trying to, is this 1.5 to 1 percentage points on the
Yes.
percentage, or is it, okay, it's percentage points?
Yes.
Okay.
So if the baseline is at 10, it would go up to or between 10.5 and 11.
Okay. Just
Basically
suggestion when you
benchmark for the
communicate
next
this,
year.
make sure it's points, because you could interpret it either way.
Thank
where
you.
it's
Yes,
written.
we have it
Yeah.
written in our formal adoption language as percentage points.
Yeah,
But
great.
thank you.
Thank you.
Thank you.
Thank you. We're going to go to Eliza online, and then we've got Sarah, Stacy, Ken, Barry, and Hector.
Thank you. With respect to the TINs and the MPIs and the provider attribution addendum, we'd like to propose that the office consider adding the TINs and the MPIs to our provider attribution addendum. And we're doing that because it's very, very difficult for the plan, given the intensive work that we have to undertake to match these various provider indices with the provider attribution addendum names. So I know it's a difficult ask. But I'd like to figure out a way if there's an opportunity for us to get this right at the onset and be able to prevent the enormous amount of work that the payers must undertake. Thank you.
Point well heard, and I think that's exactly what we're working towards.
I was wondering if you could further explain what exactly, what behavioral health services would be counted as primary care. And I'm sure when we go into the behavioral health part, we'll talk about what will be counted as behavioral health. Yeah.
Sure. So in our definition, we have included some services like depression screening and follow-up, and those types of services as primary care. And then over time, as we develop our behavioral health definition, I think as we've talked about before previously, we are looking to measure behavioral health in a primary care setting as a discrete set of services or spending. So we're looking to define that specifically, but right now includes services like depression screening in a primary care setting or provided by a primary care provider.
Let's see, we go Stacy, Ken, Barry, and then Hector.
So my question, I have two questions. One is on the PCP spend in a primary care, actually a professional capitation, where the health plan is not paying you for primary care separately. How is the primary care spend evaluated? Is it just the encounters that are billed by a physician or advanced practitioners in primary care compared to the total encounters? Or are you taking into account the in-basket messaging, all of the support structure that we have around primary care to help them that is not a claims-based or an encounter-based method?
Our definition is based on encounters and counting the encounters under a professional capitation. And I can pull up our allocation methodology, but it's essentially calculating a ratio based on fee-for-service equivalents for primary care services to fee-for-service equivalents for all services under capitation, and then multiplying that capitation payment by the ratio. So we have in our methodology that we have previously published, that is the proposed methodology for allocating a portion of capitation to primary care spending. And we worked on that with the investment and payment work group. So that's both in our published methodology so far in terms of the definition, and will be more fully laid out in the data submission guide.
So just worried about unintended consequences, because it would behoove us then to take those patient messages and creating visits, which will impact access. So there's a lot of support that's given to primary care that's not valued. So just a concern about that. The second question is the percentage for PPO. In alternative payment models, we're kind of really at the mercy of our payer partners, but not much is delegated to the provider system under PPOs. So the only thing that we can do is outreach for gaps in care, things of that nature, but utilization management is not delegated, case management, none of the services or tools that could change that cost trend are delegated providers. So I'm just concerned about the effective getting to that 60% number and having the health plans force risk on us.
Thank you. Yes, I think we've aimed to address some of the challenges in the PPO market through our APM adoption standards, but do recognize that there are both challenges and limitations to the amount of risk that can be delegated.
Okay, I want to address David's question and help CJ out with the answer. On the HPD, we expect to aggregate 92% of all claims data with the absence of the ERISA self-funded plans. We're trying very hard to generate interest from the self-funded end, which is where I came from, but we thought we had a breakthrough last month and it became a big disappointment. My former plan in San Diego reported that they had an agreement with their health plan to put the data together to submit, and that there would be no cost to do it. Then 2 weeks later, the administrator on my old plan came back and said now they want $45,000 to set it up, which kind of really confuses us because the health plans have the data and it's just a matter of aggregating it with all the other mandated data. So I don't know if that's just a deterrent. I'd like to eventually get more information on the why, but I would say right now the 92% would still be pretty good.
Okay, Barry.
Two of the areas that OCA is looking at very appropriately are the movement away from fee-for-service toward APMs, as well as expanding or at least ensuring ample access. So in a given market, if a payer and a provider have an ACO relationship, let's say it's one of the HCP land category 3, let's say it's a full risk downside ACO, those almost always have a narrower network. Will that be considered lack of access? I'll give you an example. If we used as a dot on a map Anaheim Stadium, within 10 miles there are 18 hospitals. If an ACO with downside risk was entered into, the consumer that chooses that would have fewer hospitals and fewer physicians. Let's say they had 8 hospitals, not 18. Is that considered a lack of access? I mean, is that going to be a problem? We accomplish one, but we're sacrificing another, or is it not necessarily considered lack of access if they have, in this case, 8 hospitals available? If that makes sense.
Yeah, that's a good question. I think like if it's a payment arrangement that doesn't fall into global risk, I don't think it would fall into kind of the DMHC kind of review process. Since you're saying category 3, so it's a question about the focus on kind of OCA's goals and whether that will count towards that. Okay. So
is it benefiting one? It's moving toward an APM.
Yeah.
But you're reducing the number of physicians and hospitals that are available in a broader PPO, plan or a product.
Yeah. So what we're quantifying, or at least for the measurement of for the APM data, it's about the number of members attributed to the APM model. So we'll be able to capture that in the data we're going to collect, and then separate outside of that, the plans have network adequacy rules that they have to follow. So as long as they're in accordance with kind of state law pertaining to that, like OCA is not the regulator of access, but what we definitely want to monitor access and pay attention to kind of the measures we see, the timely access measures we see from the other regulators like DMHC.
Thank you.
Looking virtually, Hector, you want to go ahead?
Yeah, thank you. Thanks for the presentation. I went to look at page or slide 65 in sort of the pathway to alternative payment models. And in particular, looking at Medi-Cal, you know, 85% of Medi-Cal patients are now in a HMO, which capitation, which, you know, I consider to be alternative payment model. So when I was reading the background materials, it wasn't really clear why it would be 55% today when 85% are in a capitated arrangement. And in many cases, the capitation is there's a delegation in the delegated model to the IPA or network. And in some cases, hospitals also accept capitation or another form of alternative payment, which is a per diem with some incentives. Um, can you kind of maybe describe why that 55% comes up in 2026 and what the differentiation is between that and capitation?
Sure. So we developed the Medi-Cal APM adoption goals in collaboration with DHCS. So we, worked with them based on their understanding of the data and not just how they are paying Medi-Cal managed care plans, but how the Medi-Cal managed care plans are then paying downstream providers like provider organizations and hospitals and other healthcare entities. And so we think this is reasonable based on our discussions with DHCS that there are several, if not many, Medi-Cal managed care plans that are paying their downstream providers either fee-for-service or fee-for-service plus pay-for-performance payments, and not all of them or not many of them are paying mostly capitation. So, and I will just note that, this is based on imperfect data and discussions with DHCS. So as we collect this data, we have noted that we will revisit these goals based on 2 years of data collection. So as we get to that 2026 adoption goal, if we are already meeting that for Medi-Cal, I think it would be an opportunity for OCA and the board and the advisory committee to revisit the goals and see if we need to make adjustments.
Okay.
David, and then OCA.
Yeah, Margaret, a comment just to add on what Stacy was saying. The dilemma being if you have professional capitation that covers primary and specialty care, how do you allocate the portion to primary care? I think your approach is reasonable. I just want to highlight that, in 2.0 development, if you were to look at Hill Physicians as an example, what you would see is there's a pretty substantial pay-for-performance component, which is much, for our primary care physicians, about 1/3 is pay-for-performance and 2/3 is fee-for-service payment. And so you would, if you use the methodology you're using, you'd understate the investment in primary care in terms of the dollars, because we've chosen to put quite a bit into pay-for-performance linked to quality, patient access, utilization. So just a thought for the future. I'm sure we're not the only group that does things like that. So pay-for-performance done by the group with the capitation and how it's allocated between primary care and specialty care would be an important thing to think about.
Thank you. Yeah, that's definitely something we considered, and we think this is a good approach for now, but we are open to revisiting this as we move forward. Also, we think as we look to eventually over time collect data from risk-bearing organizations, we can look at to see how we might have a more nuanced collection of spending there.
Thanks. Just a comment about on page 77 about the comment of behavioral health and primary care is collected as part of primary care spending. And the punchline comment being, I know we're getting into behavioral health, but if that goal gets set at 15% separate from primary care, then my comment's a moot point because that's a big win. But primary care alone could easily be 15% of our well-functioning healthcare system. And for us in primary care, behavioral health is such part and parcel. But we wouldn't want one to be pitted against the other. And that gets complicated in our clinic FQHC model, which we are part of a managed Medi-Cal, but we're still largely fee-for-service. So we're on the rat wheel and we're grinding through payments, and we have a lot of rules, one of which being I can't bill for my visit and a separate therapist visit in the same day. So we do a merged visit where I say hello and then the therapist comes in and bills under me. And uh, that's primarily a behavioral health activity, but it looks like it's a medical visit. So I don't know to what extent that's happening around the state. But the real point being, yes to both. They're hugely important. A lot of us think behavioral health should be strongly rooted in primary care and would encourage bolstering both of those to a goal of 15%.
Thank you so much for this presentation, and I really appreciate you going over the numbers. I just have a few questions and comments. So my first question is, how is telehealth incorporated into all of this, especially if we're talking about, access? We know that rural areas tend to have less providers, less access to all kinds of clinics. So where does this fall, if anything?
Sure, I can say for primary care, we've included telehealth visits in our primary care definition if they are provided by a primary care provider for a primary care service.
Okay. And then I have another question. This is kind of piggybacks over what Parker was saying, that we're kind of documenting things that's episode related. So is that based on like the primary cause, or, we're talking about a number of systems that interact, right? So if you say, let's say someone has a heart attack, well, is that also going to be related to uncontrolled diabetes? So how are all of those items going to be prioritized and categorized?
So here in the episode-based payment category, we are collecting data on how the payer has contracts with a hospital or a provider organization to provide what sometimes are called like a bundled payment, where they're paying for a cardiovascular procedure and also including pre and post-op visits and maybe some other visits along in like a set payment arrangement. So those are the types of payments we're looking for in those categories, and those would be reported by the payers based on how they contract with hospitals or provider organizations.
Okay, so just to clarify then, there's no direction or directive as to how to allocate those payments across providers.
No, not specifically. Our alternative payment model adoption goals are based broadly on the categories of shared savings and shared risk and capitation-based payment models, and increasing adoption of those models broadly.
Okay, thank you. I have a few more questions. I have another just kind of comment or point. I agree we should include behavioral health as part of primary care. Really, they're intertwined. But I'm really concerned, I love the idea of depression screening, but the fact of the matter is that you have to have a really good relationship with your patients in order to really have meaningful conversations, and not to mention time. And when you're doing a lot of documentation, right, you're in a high volume clinic, right, where primarily it's folks who are already marginalized who are going to those facilities. I don't know that we actually have adequate resources, on top of the fact that we have a dwindling clinician, we have a higher clinician shortage. I know that this is kind of something off in the future, but I just want to, really plant a seed and have us think about, what does depression screening mean that actually has some meaning and bite to it? Because I don't know about you, but how many times have you gone to the doctor, they ask you a question and you don't want to answer? Right? And for depression, especially if you're a young person and you're with parents, there are some issues about confidentiality, and you can ask them to step away, but there are often safety issues. And I see this often in communities that experience stigma towards mental health, behavioral health, especially in our community, AAPI communities, where, every year SAMHSA ranks us as the least likely group to seek behavioral health services. So I really want us to think about what that means, depression screening, and where's the first touch, right? Like, who gets to see that first? And then my last question is, how does this impact, if any, uninsured patients, clearly that's a whole other issue, but all we see it all the time where you've got people who come into the ED and they've delayed their care for so many reasons, and a lot of it is because they're uninsured. So I'm just trying to figure out where all of that fits into here.
Sure. I'll take the uninsured question first. So, yeah, California has done a great job in expanding coverage as much as we can. But the purpose, kind of the scope of OCA in terms of its data collection will be on spending for covered services or covered benefits for the insured population. So, that we will be collecting data from plans about their insured populations. So uninsured will be something that's out of scope, but in our annual reports, we do kind of, our reports are intended to be a bird's eye view of the healthcare system. So we would report on metrics related to the uninsured rate in California. And any kind of, this advisory committee and board have also been interested in out-of-pocket, out-of-plan spending. So we are also working on some analysis related to the magnitude of that spending.
Thank you. I know it's a tough question to answer, so I appreciate that.
And I'll just note for the primary care and behavioral health piece that part of our intention both in statute and at OCA for increased primary care investment is to support increased use of behavioral health integration or the collaborative care model, and for primary care practices to have more resources to provide more comprehensive care, team-based care that may include a community health worker or a social worker. So those are all kind of theories and intentions behind our effort to increase primary care investment.
Carmen and then Hector.
Yeah, I wanted to I'm trying to kind of jog my memory on when we first talked about APMs and whatnot. I think one of the questions which hopefully is, my sense is other folks have the same question, which is, I think there's a little bit of mushiness about what we're defining as an APM. And, I will reiterate what I think I said last year, maybe earlier this year, which is that, I think that we should have a broader view of APMs to include things like, that we've been considering in single payer models like global budgets and fee for time and things like that are not risk-based payments. And I know we had that discussion. So I guess my question is where are we? I assume it's going to be in the annual review of the goals for APMs. Where are we looking at kind of reconsidering what is or is not an APM, and is there going to be space to be able to ensure that things like Barry and Stacey were mentioning, that there aren't unintended consequences of shifting folks into certain types of payer models or plans just because they want to meet in part because they want to meet the APM goals, or because they, whatever is, because this conversation is related to primary care and behavioral health, is there going to be some bizarre maneuvering of what providers end up trying to consider behavioral health, primary care, APMs as a result of these goals that we're putting out? And it's kind of like a little bit of an existential question of like, is the project of trying to reach APM goals, primary care and behavioral health goals, can we make sure that we're not causing and resulting in bad behavior, or certain types of shifting patients into different categories based on, or plans based on, what OCA's goals are with all three of those measures that we're developing standards on.
Sure. So I definitely think we can look to, in many ways, monitor for, unintended consequences or negative actions based on our APM adoption goals and primary care investment benchmarks. And just to your question about how we are defining alternative payment models. So one, we are using the Healthcare Payments Learning and Action Network to define our alternative payment model adoption goals, and those payments that count towards the goals are shared savings models, shared savings and shared risk models, population-based payment models, global budgets, capitations, and fully integrated delivery system payment models. So those are the types of alternative payment models that track and meet our APM adoption goals. And then we are collecting, and we could go back to slide 67 and 68, we are collecting alternative payment model adoption data by the expanded framework categories and subcategories. So these are the categories where we are asking payers to allocate how much spending is in each of these categories and subcategories. So we are collecting data on, primary care and behavioral health integration, social care integration. We're collecting data on procedure-related episode-based payments with shared savings, et cetera. And then on the next slide are all of the capitation types of capitation data we will be collecting.
Okay, Hector?
Yeah, thanks. Well, we're going to learn a lot through this process, obviously, right? And for those of you who are familiar with our practice, we have our own IPA, and the primary care is delivered by medical groups. We trained at Kaiser, so it's kind of the Kaiser model. It's a single medical group providing all the primary care for the IPA. And the premium is not volume of visits, but what we do for the patients when they come in, which is exactly what Duncan was talking about, the magic sauce, right? His patient comes in with a sore throat, but she hasn't had a pap smear. She's already taken the time to come to the office. We give her one-stop shopping, and we do the pap smear. And in a normal practice, that puts the doctor behind because now they took extra time with the patient. In our model, we actually put fewer scheduled appointments so that we can have that facility to make those interventions. If it's behavioral health, the patient's depressed, rather than sending them away with a 30-second soundbite of counseling, we actually sit down and counsel them. By having the IPA and the risk that's involved with the IPA, we know that if we spend extra time with the patient, it saves downstream dollars. So moving from volume to value is really a critical piece of what we're going to learn here. And I like that you're framing alternative payment model evolution to 2034 as the same calendar for primary care investment to 2034, getting to that magic number, because both go hand in hand. The conundrum for safety net providers is that the feds have, onerous productivity and access requirements, which are volume driven. And if you're not showing the volume, the feds come down on you. So something we want to learn is how can we advocate for the safety net to move from volume to value as well, and not have the financial rug pulled out from under them. So we're going to learn a lot in this process. And I think, this is what we should be a learning collaborative. Thank you.
Thank you. It looks like that wraps up discussion on this item. Seeing no virtual hands and no other committee members, we will now take public comment. If you'd like to make a comment on this item, please step to the podium. If you're attending virtually, noting for the record, we have about 49 virtual attendees at this point. Please step to the podium. Seeing no one at the podium and seeing no hands raised, I'll give it a moment. That concludes public comment on this item. We will move on to item number 6, and I'll turn it over to Margaretta Brandt.
Thank you again. So now we'll turn to an introduction of our behavioral health definition and investment benchmark work stream. So this is a work stream that we've just recently gotten underway with our investment and payment work group. And Debbie Lindes and I will provide an introduction. So I'll start with the first few slides. So if we could go to the next slide. And then we can go to, sorry. Yeah, so just wanted to highlight again here, as we've done for other areas, that behavioral health investment is part of our overall portfolio of focus areas to promote high value health system performance alongside the spending growth targets and our efforts to monitor consolidation in the healthcare market. So if we could move to the next slide. Again, we'll do, as we usually do, a recap of the statutory guidance that that directs our work for behavioral health and primary care investment. So here, OCA is required to promote a sustained system-wide investment in behavioral health care, and in doing so, measure the percentage of total healthcare expenditures allocated to behavioral health and set spending benchmarks. So to complete those tasks, similar to how we've done for primary care, we'll need to define behavioral health spending for the purposes of measurement and determine what portion of spending will count towards the benchmark. And this will depend in large part on what are the priorities that we set, and we work with you all and the investment and payment work group on what are the priorities for sustained system-wide investment in behavioral health. And OCA's mandate to measure and benchmark spending is a component of system-wide efforts to improve health outcomes. And in the case of behavioral health, the statute requires OCA to promote models that integrate behavioral health with primary care and broader social and public health services, encourage the adoption of alternative payment models that enable improved access and team-based approaches to behavioral health care, reduce disparities in behavioral health care, and expand access to telehealth and other solutions. So in the next few slides, we'll provide a bit of context about, why we're focusing on behavioral health, which many of you know. So for many states, the increasing focus on behavioral health investment was in part due to the dual pandemic of COVID-19 and the behavioral health crisis that only intensified as a result of that social isolation and economic instability, greater acknowledgement of systemic racism, and other factors that were occurring alongside the pandemic. And as noted here, nationally and in California, nearly a third of adults report symptoms of anxiety and depression or depression. And unfortunately, we know that too many of these individuals are not receiving appropriate treatment, as we've already talked about today. A CHCF study from a few years ago found that nearly 2/3 of adults with mental illness in California did not receive treatment. And the bright news here is that we know that there are potential solutions, such as integrating behavioral health and primary care and other ways to improve access to behavioral health services, and as a result, aim to improve health outcomes. So on the next slide, we'll provide, again, a bit more background data. So this slide shows the distribution of behavioral health diagnoses for emergency department visits and inpatient hospitalizations in California in 2021, using data from HCI's patient discharge and emergency department hospital encounter data. And for 2021, there were nearly 1 million emergency department visits and close to 900,000 hospitalizations in California with a mood disorder or anxiety listed as the primary or secondary diagnosis. Substance use disorders, including alcohol, stimulant, opioid, or other substance use related disorders, were listed as the primary or secondary diagnosis for over 1.3 million hospitalizations and emergency department visits in 2021 as well. So altogether, mental health and substance use disorders, including co-occurring disorders, were present on about 27% of all California emergency department and inpatient encounters in 2021. So that we know that individuals with behavioral health conditions are showing up in the hospital and the emergency department. And on this next slide, just want to, now that we've covered a bit about the kind of rationale and why this is such an important focus area, for OCA. Want to again share a bit about our investment and payment work group. So the OCA team has been meeting with the investment payment work group monthly for more than a year to inform our work on the alternative payment model adoption workstream, primary care, and now behavioral health. So members highlighted in the light blue have recently joined the work group as we transition to behavioral health, as we wanted to bring in more members with a variety of behavioral health expertise and background to help inform and guide this work. And if we can move to the next slide. I'll just here transition over to Debbie. So OCA's first behavioral health legislative charge is to develop a framework for measuring behavioral health spend. And so for this section of the presentation, Debbie Lindis, our healthcare delivery system group manager, will provide an overview of the framework that we plan to use for behavioral health spend measurement. And then we'll transition also to focus about investment.
Thanks, Margaretta. And good afternoon, everyone. I'm Debbie Lindis. I use she, her pronouns. And as Margaretta mentioned, I'm the manager of our healthcare delivery system group within the health system performance branch at OCA. Under Margaretta's guidance, I lead our work on primary care and behavioral health investment, as well as workforce stability standards. And I'm happy to be here today to introduce you all to OCA's behavioral health investment work. You can go to the next slide, Wayne. I'll start by providing some national context for our discussion. Across the United States, approximately a dozen states measure behavioral health clinical spending. 9 of them measure behavioral health spending within primary care, and those are shown in light blue. And 3 states, shown in the dark blue, measure behavioral health spending across the full care continuum. California will join those other 3 states to measure behavioral health spending across that full continuum of care. Next slide. So I'll begin by reviewing OCA's key use cases for behavioral health measurement, which will inform how we structure our behavioral health spending definition. As required by statute, OCA will measure behavioral health spending as a percentage of total healthcare expenditure, or THCE. And as part of that measurement, OCA would like to understand spending on both mental health care and substance use disorder services. We'd also like to understand the distribution of behavioral health spending across different types of services and care settings, including primary care. And finally, OCA proposes to establish a focused benchmark for behavioral health spending that supports statewide goals and priorities. And we'll discuss this further in a few minutes. Some analyses, such as understanding the portion of THCE spent on behavioral health services in an outpatient setting, may be best served by OCA's data collection. And other more complex analyses, as we've discussed earlier today, may best be served by the Healthcare Payments Database, or HPD. And on this slide, the graphic is adapted from a recent Milbank Memorial Fund cited in the footnote here that was authored by our colleagues at Friedman Healthcare. In alignment with statute, OCA is focused on measuring spending for those services that are part of total healthcare expenditures, which are clinical services paid for by public and private payers through claims and non-claims payments. And we recognize that this is a relatively narrow view of behavioral health spending. In the future, OCA will explore the possibility of using supplemental data sources, such as some of those shown in the other quadrants on this graphic, to capture other spending. And in particular, we want to acknowledge the significant direct spending by consumers for behavioral health services. While OCA's current data sources won't be able to quantify that spending, OCA, as has been discussed already, it does plan to study out-of-pocket, out-of-plan, or self-pay behavioral health spending as part of a separate work stream, which you heard a little bit about during this committee's meeting last May. We will be collaborating with the out-of-plan spending measurement team to ensure that insights are shared across these work streams. Next slide. So here's the high-level equation for measuring behavioral health spending, and it looks very similar to the one you've seen before for measuring primary care spending. The numerator includes claims and non-claims based payments for behavioral health care. This numerator is then divided by the total of all claims and non-claims based payments, or the total cost of care, and that quotient is multiplied by 100 to arrive at behavioral health investment as a percent of total cost of care. Much of the investment and payment work group's effort will focus on developing recommendations for what to include in the claims-based and non-claims-based components of this numerator. Next slide. Similar to the approach for measuring primary care, OCA is proposing to use 3 modules to measure behavioral health spending. So these are behavioral health care paid via claims, behavioral health care paid via non-claims, and then behavioral health in primary care. The behavioral health in primary care module will be measured separately so that it can be included in analyses of either behavioral health or primary care spending. And OCA initially defined this module with input from the investment and payment work group as part of its primary care work. Over its next several meetings, the work group will be informing OCA's development of the behavioral health care paid via claims and non-claims modules, and will also weigh in on whether any adjustments should be made to the behavioral health and primary care module. And before we, I think it's okay, you're there. But before we move on any further, I just want to point out one potential important difference between our approach to behavioral health versus primary care investment, which is that while we will measure overall spending on behavioral health care, our investment benchmark may focus on a subset of conditions, care settings, or populations that are a high priority for increased investment. Unlike primary care, which occupies a specific place in the healthcare continuum, behavioral health care treats specific conditions across the entire continuum. And increases in some types of behavioral health care may serve OCA's goals more effectively than others. So a more focused benchmark for behavioral health spending would acknowledge this, and we will discuss that benchmark more in just a few minutes. Now you can go to the next slide. So OCA proposes a phased approach to defining and measuring behavioral health spending. Our initial measurement and data collection will focus on the commercial and Medicare Advantage markets to reflect OCA's data collection approach. And our next step will be to adapt the commercial market definition to the Medi-Cal market, possibly including data sources that are specific to Medi-Cal and making refinements as needed. And then we will iterate and revise the definitions over time as we learn from experience. Next slide. So OCA will be collecting data to measure behavioral health spending from the same entities that submit data for measuring total healthcare expenditures, or THCE. And as I mentioned a few minutes ago, the statute requires that behavioral health be measured as a percentage of THCE. So for consistency and also to minimize reporting burden on data submitters, our data source for measuring THCE and behavioral health will be the same. Behavioral health spending data will include both claims and non-claims payments, with non-claims payments organized into the expanded framework categories that you are familiar with. And OCA will develop definitions and technical specifications for the submission of behavioral health spending data, and will offer technical assistance to support accuracy and consistency of data submission. And this will be particularly important for the non-claims portion of spending. OCA's initial efforts at measuring behavioral health spending will focus on the commercial and Medicare Advantage payers and their members, as I mentioned. Next slide. So now I will give you an overview of OCA's work thus far related to setting a behavioral health investment benchmark. Next slide. So this slide shows OCA's proposed goals for improved behavioral health care. We want this care to be accessible, comprehensive, coordinated, equitable, and of high quality. These goals were adapted with input from the Investment and Payment Work Group from a policy brief issued by the California Health and Human Services Agency. And the work group will be referring to these goals as touch points as it continues its discussion of behavioral health investment priorities. Next slide. So this is a logic model that we developed to illustrate OCA's role in improving behavioral health outcomes through its measurement and benchmarking activities. So our work supports other stakeholders' actions, which we hope will result in achieving the system-wide behavioral health goals. Starting on the left, we see a two-way relationship between the system-wide behavioral health goals from the previous slide and California stakeholder actions. So in one direction, the system-wide goals are motivating stakeholder actions, and in turn, those actions should result in movement toward the goals: more accessible, comprehensive, coordinated, equitable, and high-quality behavioral health care. On the right, we see OCA's role in the model. The measurement, public reporting, and benchmarking that will come from OCA give California stakeholders information and analysis to support their actions in pursuit of the system-wide behavioral health goals. Next slide. Go to the next slide, Wayne. There we go. So these are some examples, just a few, of how those interactions could work. So OCA could measure and report mental health and substance use disorder spending separately to show differences in spending between those categories and compare it to the need as identified by prevalence data from other sources. OCA could measure and report spending across service categories to highlight the need to rebalance care towards outpatient care and prevention. And OCA could recommend benchmarks for increased behavioral health spending for specific populations, services, or care settings that would motivate stakeholders to invest more in those areas and move the behavioral health system toward the goals. Next slide. So here's a list of some of the key decisions that OCA will need to make with input from the Investment and Payment Work Group, you all on the Advisory Committee, and the board. So for example, the work group has begun and will continue to discuss its priorities for measuring behavioral health spending and will provide input on the phased approach to measurement. We'll also consider decisions around the components of claims-based spending. This conversation will include which diagnoses, which services, providers, and care settings OCA may include in a definition of claims-based behavioral health spending, and we'll also need to define non-claims spending. The key decisions around benchmarking will include whether to increase behavioral health spending across the continuum of care or to focus on particular conditions, care settings, or populations based on priorities for increased investment. And finally, the work group, advisory committee, and board will weigh in on defining the benchmark level and a timeline for achieving it. Next slide. There we go. So as I noted earlier, currently 3 states, which are Maine, Massachusetts, and Rhode Island, have defined behavioral health for the purposes of measuring spending. Additionally, the Milbank Memorial Fund has published recommendations for a standardized definition with inputs from states and other experts. And this slide shows how these states and the Milbank recommendations approach those key measurement decisions that I noted on the last slide about claims-based spending. So claims payments include information about diagnosis, care setting, and provider, among other things. And each of these elements can be considered in defining an expenditure as behavioral health or not. So all 3 states, as you can see here, restrict their behavioral health definitions by diagnosis, while no state limits its definition to only certain providers. States take different approaches as to whether and how they categorize care by care setting. Just as an example, Massachusetts uses a combination of services and care settings, such as inpatient, emergency department, and outpatient, to categorize its care delivery. Next slide. And this final slide shows our tentative timeline for the behavioral health work. We plan to meet with you all again in January of 2025 after we introduce the board to this work stream in December. We'll then provide another update here and seek your feedback in March of 2025. And OCA is currently planning to take a recommended behavioral health investment benchmark to the board for approval next May. If needed, we may adjust this timeline, and if that's needed, we'll keep you updated on any changes. Thank you. And now I will pause for questions and discussion.
Hi, thank you again for this presentation. You know, obviously behavioral health is something that's very important to me. I understand like the difficulty involved in trying to address something that feels so elusive and abstract at times. And, on that note, I'm wondering, because something that we hear all the time among our communities, providers, and clients is that, limiting things to just diagnoses, right? It takes this position of, well, you have to, first of all, be able to get a diagnosis. And that for a lot of people is really, really difficult. So I guess what I'm trying to plant here is I'm wondering if there will be greater development on understanding what behavioral health care could look like outside of just having a diagnosis, and also outside of specifically a behavioral health clinic. Is that something that will be considered in the future?
Sure. I'll just note that, we have not developed a proposed definition yet, and these conversations and development work is ongoing. So we haven't made a decision yet about whether diagnosis is a key portion of the definition. I'll note that there are a variety of opinions on this, especially in our investment and payment work group, but some folks have expressed that it seems critical to use diagnosis in order to track spending for behavioral health services, especially in like a non-behavioral health setting, like a hospital, whereas maybe it may not be as necessary if you're just looking at spending by behavioral health providers. So it's an ongoing discussion, so we definitely welcome feedback.
Thank you.
Thank you. We've got Sarah, then Janice, Hector, and then David.
I noticed in the slide, page 83, where it showed the investment and payment work group, I didn't notice any representatives of like clinical professional organizations or groups, like let's say the California Psychological Association, people who are experts on what the standard of care is and what mental health treatment is. And I feel like that's a very essential voice to provide input on our behavioral health decisions. And the other thing I noticed also is just not a direct patient care provider, mental health worker who's not in a managerial role. Because I do think that that perspective is important too, because not to say that someone in more of a manager or higher level role can't have a great understanding of what's going on, but it's just a different perspective, someone who's actually doing the work and that's their total focus. And the other thing I noted down, and I guess I was trying to, when I asked the question about integration of primary care and behavioral health care, I wasn't quite formulating what I wanted to say, but kind of almost like, what does this mean in general? Like, so when you're saying behavioral health care that's provided in a primary care setting, does that just mean like, let's say specialists are located in the primary care office providing that care, so it's just like side-by-side care? Or does it mean a primary care provider is well-versed in psychotherapy or psychotropic medication management? And let's see, the other question I wrote down, focus. Just some like quick notes I wrote, and of course the work group I'm sure is going to be talking in depth about this stuff, is it kind of seems to me that focusing where the access to care issue problems would be really the most important priority, because that's where we can get the most bang for our buck. And I'm thinking of things like individual and family therapy, evidence-based group therapy. So that is, there's a certain number of patients, a restricted number of patients, and research literature guides what happens in the group, how often the group is. So I'm not like classes or arbitrary numbers of groups or sessions. Wraparound type services. So that services maybe you'll see more like in a setting where I work at the county, where they have an individual therapist, they have a case manager, they have a peer partner and a psychiatrist, and they work as a team together. And that usually is to help, prevent a decompensation and need for higher levels of care, and hopefully to move them to a lower level. And then things like any kind of residential treatment, whether it's crisis residential, substance use rehab, and voluntary psychiatric hospitalizations. And I would say not that adults shouldn't be focused on, but definitely making sure children, because that intervening at that stage is going to also provide a lot of bang for our buck. And I think the last thing I noted down was like the thing about restricting by diagnosis. So does that mean it'll, like, if there's a certain diagnosis and it's not just, oh, the diagnosis is added, but that service isn't focused on the diagnosis? Because I see that a lot in notes where all the diagnoses for someone is added to a visit, even though they may just check in, like, oh, are you seeing your therapist? Oh, great. But maybe that's not what is meant by this. It's if the diagnosis is there and the session or a certain part of the service is focused on providing treatment, providing care.
So I'll just add a few notes, and welcome Debbie to add. So for restricting by diagnosis, this could be in a few ways. I think a lot of folks that have looked at either primary only or primary and secondary diagnosis on the claim. We could also approach the definition of applying that primary or secondary diagnosis plus a behavioral health service by a behavioral health provider, so we could have a more strict or specific definition if that is, the interest of the advisory committee and the board and the work group. And then I think for additions to our investment and payment work group, we're happy to connect offline about folks that should be added to the work group. And the work group is not the only opportunity for input. We're happy to meet with anyone outside of the work group who would be interested in providing input. So we can definitely follow up with you about that. And I think one of your other questions on integrated behavioral health. So this would include things like depression screening and follow-up and those types of care, and then also include claims-based codes for integrated behavioral health, like using the collaborative care model and providing services in that manner. And I think we're not, in our definition, are not strict about specifying how that integration looks and what it looks like, but we are trying to capture the claims that would include that type of care, and through non-claims capture that spending through like the primary care and behavioral health integration, non-claims data collection, and those other avenues.
Yeah, I think the only thing I would just add is the diagnosis question is a big topic of discussion in the work group, and that the tricky piece is if we were to limit by diagnosis, we would probably want to be as broad as possible about what diagnoses would count. But one of the challenges is if we're trying to measure, say, for example, in primary care or the emergency department, if we want to capture behavioral health, but not everything that happens in that setting, we have to have a diagnosis list. There's no other real way to distinguish behavioral health care from care that has nothing to do with behavioral health except by diagnosis. But I have a creative idea.
I like SB 855 that has for the state determine what the standard of care is or medical necessity. It includes treatment for any diagnosis in the DSM. So, I mean, that's like restricting by diagnosis, but it's not saying, oh, just 5 diagnoses from the DSM. So, I mean, if that's needed to identify, you know, a behavioral health service, I mean, that seems to make sense to me.
Yeah, claims use ICD-10 and not DSM, but the idea would be to be as broad as possible without including things that are just not related to behavioral health in any way. So, yeah, it'll be a big area of work for sure. Thank you.
All right, we've got Janice, then Hector, David, and Carmen.
Thank you. I'm forever mind-boggled by the breadth and scope of what this office is charged with analyzing and figuring out. So obviously, behavioral health is such a crucial part of this healthcare continuum that we're looking at. And for, I guess, my membership, we represent all the way from our state psychologists and psychiatrists, licensed clinical social workers, down to the county level as well. And I appreciate, I don't remember the name of the person that spoke before me, but really appreciate the comments about how we really understand this issue by including the voices of the behavioral healthcare workforce. You know, there have been a lot of investments due to the passing of Proposition 1 in mental health care. And our members were admittedly maybe a little bit hesitant about supporting it because of the lack of investment in the workforce in that proposition. And it's going to be really important as we see just how the funding for MHSA really boosts, hopefully boosts access to care. So I would like to just, I guess, add my voice into having someone who might be able to talk about what it's like on the ground and where there are ways that we can find the ability to increase this workforce, because there is such a huge need for additional licensed clinical social workers and psychologists and MFTs. And so thank you.
Thank you. We got Hector, David, Carmen, Parker, Barry.
Yeah, I think just following Janice and Sarah's comment about the proficiency of the clinicians, because, you know, we're going to create an expectation and not everybody's ready to deliver those kinds of services. You know, I mean, speaking as a family physician, I can point, and I run a residency program. I can point to, we have an obligated curriculum where a significant amount of the training, and we have a psychologist and LCSWs as part of our team, required training for family physicians is in behavioral health, learning to diagnose and manage common conditions, learning how to prescribe psychotropics safely and drug-drug interactions, et cetera, as well as mood stabilizers and for other diagnoses. And we used a collaborative care model by having a psychiatrist, adult psychiatrist, and a pediatric and adult psychiatrist as part of our IPA network. They participate with us on this, and they also are involved in teaching. But not everybody's set up that way, and that's one of the problematic areas that I think we should be a little cautious moving forward. I'll just give you a scary story. A few years ago, I got a call from a physician who wanted to join our IPA, so I went to visit their office. And it turns out they were seeing 80 patients a day. And one practitioner, there's no way that they could provide good quality care. And, you know, so I already knew they're not going to be part of our network. But I did ask them, so what do you do when you see depression or some other behavioral health issue? And they go, you know, we don't see that here. So that's part of the problem, all right? So we need to approach with caution, because we may end up creating an expectation that can't be met, or that we can't verify. And we know that there is a workforce shortage in behavioral health. And so this is a time that we want to be methodical and careful as we move forward. Thanks.
Thank you. David?
I was surprised you didn't talk about the behavioral health carve-out companies when you discussed this. You know, they have the lion's share of the dollars that are spent providing these services, and I would advise you to consult with them in terms of how you'll extract this data. The other thing I'll tell you, and I don't think this is the case for all plans, but I'll tell you what I hear from primary care physicians is that if they submit a claim to the health plan where the primary diagnosis is the behavioral health diagnosis, it gets rejected because they say, no, that's going to be paid by the carve-out, like an Optum or a Magellan. And primary care physicians are usually not providers in those networks. So in order to avoid that, what they will tend to do is they'll make sure it's a secondary diagnosis. So in other words, some behavioral health is being provided by primary care physicians, but it's not directly tracked as the primary diagnosis for those payment reasons.
Thank you. Carmen?
Yeah, I had, when I saw the numbers on hospitalizations and behavioral health, related to hospital and emergency room visits, I think, the question about like what counts as a behavioral health visit really comes to mind. And I think it may be part of this discussion about what's a primary or secondary diagnosis. I think the thing for CNA nurses, what we see, what our members see a lot is that, either someone comes in for an acute care reason and their behavioral health condition flares up or something triggers some sort of need to respond in a behavioral health manner. But we wouldn't want to necessarily push someone out of a acute care setting simply because they have a behavioral health condition. So I want to make sure that when we're coding what is or whatever we're considering behavioral health and behavioral health services isn't inappropriately shifting people to certain settings, or that we're looking at the investment correctly, because we also are trying to get people with behavioral health needs are going to always go to the hospital. So we're encouraging hospitals to invest in training for people for ED nurses, for med-surg nurses, anybody who may encounter a person who has a behavioral health condition. You could have somebody who has a mental health condition who has a broken arm, for example, but then being in the emergency room may lead to some need for behavioral health services. So we want to make sure that those are counted, and that we're also encouraging this additional training in different workforce training within the hospitals, and not necessarily hyper-focused on the settings, although settings are important, and we do need more, we need to make sure that patients aren't just sitting in observation units, and that's counted as a behavioral health, investment by a healthcare system, and that they're actually getting the care that they need. And I know that there's a lot happening in terms of making sure that folks get the services that they need. But I want to make sure that when we're saying what is behavioral health, what is not behavioral health, we're kind of considering all the different types of services that may be provided. And I understand the working group is grappling with these questions. I think a good kind of existing example of how complicated this might be is like, how do we treat behavioral health navigators within a healthcare system? I honestly have no idea how that should count or not for the behavioral health investment benchmark. I would think that it would be included, but we have to make sure that the services provided are actually adequate and appropriate. I don't know. Lots of questions. Sorry that I probably didn't help.
Thank you. Parker?
I think there's going to be a similar comment to others. This is very complex work you guys are tackling. And I'm not the expert in this, again, from my corner of family doc and in primary care. Certainly the 4 areas that you put out in the pie chart of kind of how to look at these different buckets of what constitutes this definition, and the medical claims one, to me, makes sense. That's my brain and a good place to start because it's probably the most concrete. And if the goal is incentivize it, like your chart there on kind of page 93, that sounds to me like the build it and they will come, meaning as you drive incentive to this. My guess is there's way more money being spent that we aren't tracking, that people don't know. It's just private spend. You go to a private therapist, you go to an acupuncture, you buy vitamins online that you think make you feel better, all of that. But as we were to build an actual availability and accessible and high quality behavioral health system that does have medical claims attached, then I think those untrackable costs will come down and people will come into that medical claims world. That might be my bias towards the medical claim. And I'll just leave you in terms of this complexity story of how do you really count these dollars. So in our primary care clinic, a patient of mine who broke her ankle, she went in the hospital. Turns out she broke her ankle because she was drunk and she went in a rapid alcohol detox, but she, of course, told everybody she didn't have anything to drink. She was 2 weeks in the ICU with a Wernicke's encephalopathy. Anyway, then we could come back and now she's managed in our MAT clinic, medication assisted treatment, which was originally for the opioid use disorder around heroin and then now fentanyl. But it also turns out that alcohol is a pretty popular drug of abuse. And so we essentially now can, with putting shots in people's arms once a month, we're having amazing control of people's symptoms and behaviors and really good and great resolution. We're decreasing, great decrease in hospitalization, of course. The point being, when we see this patient in the clinic, of course, in this patient's case, we might bill the alcohol use disorder. And that covers to get them the shot of their Vivitrol for the month. But behind that alcohol use disorder is a massive mental health need. And so when they come into the clinic, I'm billing that, or in my primary care clinic, I bill it under the alcohol use disorder. But that person, that's only kind of the second layer of that onion. The next thing we're putting in place is all the behavioral health support that we need. But the main part of the claim is still going under AUD, AUD, AUD. But we have social worker, counselors, and all those additional support people that Sarah mentioned. They're in this team. How you allocate that out and say, is that under addiction services or behavioral health or primary care? I don't know, but we'd say yes to more. 15 of each. We'll take it.
Thank you. So I've got Barry, Kieran, Katie, Simona, then Sarah, and we'll try and wrap up this item.
Goodness. 6 or 7 years ago, our health system began to embed behavioral health practitioners into the primary care practices. When the medical group is capitated for their services, there's no bill, there's no claim, there's no payment. So how will you track those services when there's no claims payment or payment made?
This is, I think, similar to the challenge with primary care. I think we'll have to address this in looking at how we might use encounter data or other data to track, behavioral health services provided in a physician organization or under capitation generally.
Thank you. I've got Kieran, Katie, Simona, Sarah, and Janice, and then we'll move to public comment.
Great, and thank you so much for this. And I know we've had the opportunity to talk about it offline, but just for the sake of this meeting, I'll share our thoughts here, which is, I think, for the whole OCA effort, right, our goal is a better and more affordable health system. And I want to make sure we're keeping that in mind for behavioral health, because I think for primary care, there's research and evidence that when we invest more money in it, that results in better health outcomes, and that results in a more efficient and affordable health system. But to my understanding, that is only true for primary care, right? Otherwise, we know spending more money on healthcare doesn't necessarily get us anything, right? And so I want to be really careful in the behavioral health context, because I'm not aware of any evidence that actually just a global spend more money on behavioral health care improves people's behavioral health outcomes, which is not to say, of course, there are gaps. Of course, there's places where we need investment, but I would hate to see the state set an overall goal for investment in behavioral health care and push systems in that direction, because it's very easy to spend a lot of money on behavioral health care and not get much to show for it in terms of health outcomes, right? You know, institutional care is very expensive and has a very poor track record of outcomes. And so I think we need to be careful about what we're counting. So I appreciated the chart about the other states and the ones that looked at it by care setting. I think that's one way to do it, is like, what kind of behavioral health care do we actually want to incentivize? Because I don't think it's across the board where we want to see more and more and more spending. And I also think when you talked about the goals, I know you have access, and then on the next page within access you have affordability, but I think affordability should be an explicit goal here that's sort of pulled out. Number one, because you're the Office of Healthcare Affordability, but number two, because affordability is a very specific issue in behavioral health, where people are spending more money, more likely to spend money out of pocket on behavioral health by, I can't remember, 5 to 10 times than anything else, right? And so if we're getting the health system to invest more in behavioral health care and certain types of behavioral health care, that needs to mean that individuals are spending less out of pocket, right? And so I think that needs to be a sort of a very specific goal of this effort as well. And then I'll finally just say I agree with Sarah on sort of a lot of the pain point for access here being sort of in that individual family therapy, evidence-based groups. And so we just point that out as an area for a particular focus. Now, we are very big supporters of access in mental health prevention, but I don't know that we're convinced that actually the health system is the best place to do that work. And so that's why I sort of look towards what the health system is responsible for, right, and how we measure that.
Can I pause you for just a moment? We're going to see if you're, grab the mic next to you. Thanks.
So my realm right now, as I learn this space, is Monterey County, but the majority of our educators and our group receive their behavioral health through telemedicine. And though I think you can parse that out separate from primary care, I just wanted to mention that is, we do have a desert in Monterey County for behavioral health, so the only option that many folks have without paying, as Parker mentioned, separate from insurance, is telemedicine.
Thank you. Samana, Sarah, Janice?
I did have an interest in what Karen said about affordability, and within, when patients aren't paying out of pocket, that's going to be a huge win. And then what sorts of outcomes research do we have? I think there is a challenge there. But the point I wanted to make is that it's a deeply clinical level 2 thing that I think all the family doctors, including Dr. Flores, will appreciate. That my biggest wins, the sort of clinical situations I am most proud of, without giving you lots of details that I'd love to, are the patients that come up maybe once in a week or two, that take years of clinical expertise to take that person who has gone to the emergency room 50 times and they show up new. And I have literally had stacks of records, this big paper, to wade through and say, this has to stop, this is duplicative, what's going on, this is anxiety. These are not diagnoses that are like really in the behavioral health sphere in terms of easily identifiable. They are constantly coming up as high-level, complex, high-use patients with, let's say, chronic pain and behavioral health. So I leave that problem with you to think about. Everyone's bringing up, how does that overlap happen? That's my decades of experience bringing the behavioral health to patients who are nominally not. I can give you just a long, long list of patients that affordability-wise, I've brought their care down to something much more rational. It's all a family doctor providing behavioral health, if you will.
Thank you, Sarah.
I just wanted to kind of build off of something Parker was saying, like if we're taking that example of that young lady who has alcohol use problems and is getting the injection, it made me think about how, and like, oh, underneath that, there's a lot of mental health issues. I mean, so in my current job, I just do assessments for people needing mental health services. And I mean, probably many people could echo this, but I don't think I ever assess someone who has a severe substance use problem or any kind of substance use problem who doesn't have an extensive history of trauma or a reason why they've turned to substances. It doesn't have to be the case, but that's very common in the clients that come into our door. And so whenever we treat one small aspect of someone's presentation, but don't address the other aspects, it's not going to produce the outcomes that we would want. And it makes me think about, again, this is an example, things are changing at my workplace, but historically, they only provided medications to people with severe mental illness, and they didn't provide individual therapy or some other supports that are really needed and actually the standard of care when working with these diagnoses. And I'm seeing these people re-enter the door as like a readmission. And it makes sense that they, dropped out of treatment, didn't get better, because when it comes to, let's say, someone with severe mental illness who can benefit from a medication treatment plan without those other supports, the individual therapy, the peer support, the chances that something will come up which will lead them to drop out of treatment or experience, doubts about why they should continue medications and then spiral deeper, which worsens their prognosis. It actually, I believe, at least from my anecdotal experience, that if we did give people actually what they needed in the standard of care, it would be more effective and it wouldn't lead to these long, prolonged, ever worsening conditions that people with mental health and substance use disorders have. And maybe something kind of Kieran had mentioned about involuntary treatment or institutionalization. I mean, investing in these lower levels of care can help prevent institutionalization. Really, it's a social justice travesty if all we're doing is not providing them the care that they need, like not providing people the cancer care until they are at the last stage. And then, oh, you have to get all your rights taken away and be in a psychiatric hospital. And at that point, their illness may be such that it's even harder to regain their previous level of functioning, or they may have a traumatic experience in the hospital. And then I think the other thing I was going to mention, I'm totally forgetting now. If I remember, I'll raise my hand again.
Thank you. We'll go to Janice and then we'll wrap up this item.
Yeah, I'll be really quick. Carmen reminded me, and grateful for her remarks on behavioral health, that it's not often just in a care setting. And there is a missing voice from the work group, and that is the EMS community, who are increasingly tasked with responding to behavioral health emergencies. The 988 suicide and crisis lifeline, and the emergence of the behavioral health task response teams. They've enhanced support for those in crisis, but also present unique challenges in sustainable collaborations and being impactful. And obviously, when an EMS provider is responding to a crisis, a behavioral health crisis, there's also increased costs for the patient to be transported then to a psychiatric facility or to the ER. So I think that's a really important voice that's missing from this work group as well.
Thank you. All right.
Hi, I just wanted to say one last thing as far as this work group. You know, we work a lot with people who have lived and living experiences with using drugs. And I think something that we talk about often is there's just not enough peer support or peers who are getting paid. So, you know, they're really leading the revolution in behavioral health, people with lived experiences. So I'm wondering if there's a way to better incorporate them into these decision-making practices and tables where we all discuss, because they're very much part of it and want to contribute and have a lot to contribute because they have the experiences that allow them to connect with people who are really, you know, suffering or being challenged by substance use.
Thank you. Circling back to Sarah, I think you remembered your comment.
I did. I think at the very last advisory committee meeting, I brought up that Research Triangle Institute study, 2024 study on the behavioral health workforce and how out-of-network use many times higher than medical or surgical treatment. And that this study, I mean, they use data from some large commercial insurance claims database, that provider shortages do not explain the disparities. And they found office visit in-network reimbursement were much lower for behavioral health providers. So like psychiatrists and psychologists were reimbursed much lower than like a physician's assistant who's not in behavioral health. And they did these comparisons based on like Medicare reimbursement benchmarks. I guess the reason I bring that up is so there's money being, well, obviously money being spent outside of our healthcare system to get needed, necessary mental health care. And that money needs to be brought into the system. So, well, one, so people, you know, they have health insurance for a reason. I mean, what's the point of health insurance if it's not going to cover needed care? And then two, you know, it's the privilege who can pay out of pocket, and that's who gets the needed care. And obviously that's not what we want, I'm assuming.
Yeah, I just really want to thank folks for this very rich conversation. You've given us a lot to think about in terms, you know, I agree with Karen that there's a difference between behavioral health and primary care in terms of what the research shows and what we're trying to do. You've all pointed out the complexity that our team has done a great job of thinking through. And I think we've long looked at this issue of out-of-pocket, out-of-plan costs, and there is a lot of that happening on the behavioral health side. So, and we're looking at potential data sources to track that. And in terms of, you know, positions, folks with lived experience, you're all here to help bring perspectives to the table, and we know there are folks not at the table, but very much appreciate the input.
All right, that concludes discussion on this agenda item. We'll move to public comment. Please step to the podium, or if you're online, raise your hand, and please try and limit your comments to 2 minutes.
Beth Capel with Health Access. We, and those of us who worked on developing what has become OCA, which was an effort that went on for 4 or 5 or 6 years before the law was actually enacted, were well aware of both the challenges we face on the behavioral health side and the acute needs. And I would commend to all of you slides 81 and 82. Slide 81 says that 2/3 of the people with mental health symptoms don't get care. I think from this discussion, I would say that there are a whole lot more people who haven't presented as symptomatic, who in fact needed that care. And so the problem's even worse than that suggests. Similarly, the use of emergency rooms and hospitalization when care could more appropriately be provided in another setting is a very important focus. From our perspective, it's not any different than managing asthma or diabetes or hypertension. You shouldn't be doing those things in an emergency room, and that's also true of many mental health conditions and substance abuse disorders. We appreciate the recognition that there is so much out-of-pocket spending and of the lack of affordability and the inequity that goes along with that. People who can afford to pay out of pocket are the people in the top 20 or 30% of the income range, not the rest of us. And so we need to keep that front and center. The complex primary care in some ways is much simpler because all of that gets paid for out of total healthcare expenditures. That's not true for behavioral health. And a lot of the misalignment of resources and services arises from the multiplicity of funding sources and funding streams. And so that's part of what the work group's been grappling with. The objectives should be the same to get us to a well-functioning health system where mental health and substance abuse treatment are as much part of that system as physical health is. So thank you.
Thank you. Looking virtually to see any hands raised, noting for the record, we have about 43 virtual attendees, seeing no hands raised. Looking back to the room, seeing no one at the podium, we'll give them a moment. All right, that concludes public comment on this item and concludes our meeting today. We are adjourned.